Affairs. We are live streaming now. Welcome to EHE, Education, Health, and Environmental Affairs. I'm Cheryl Kagan, the Vice Chair, and Senator Pinsky has some meetings, so he's going to be in and out a little bit. And so I will be trying to handle things today on 7 wonderful bills. I can just ask you, if you are going to be testifying today, I want to note that for the first time we have a clock here. It will be visible. The first witness gets 5 minutes, the sponsor's witness. Other witnesses after that get 2.5 minutes. I will cut you off because we always have a lot of work to do. So if you can please try to respect the clock, and then there will be questions from committee members afterwards. The second thing is, if your full name, first name and last name are not in your little Zoom box, if you could please go to the upper right corner of your Zoom box and just click rename. Some people like to put their affiliation. If you're with a department or agency, you can do that as well. So with that, we will begin with Senate Bill 19, Senator Lamb, Pharmacists, Administration of Maintenance, Injectable Medications, Treatment of Sexually Transmitted Infections. Senator Lamb, you may begin.
Oops, got to unmute myself. So thank you, Senator Kagan, and to the committee. I'm happy to be here to present Senate Bill 19. So for the record, Clarence Lamb, Senator in District 12. Senate Bill 19 may sound familiar to many of you because it deals with maintenance injectable medications. And what it does is it expands on the definition that was started last year through statute that through legislation that we passed into statute by clarifying that the existing definition of maintenance injectable medications would authorize pharmacists to perform these types of injections for sexually transmitted infections or diseases, or STIs. So STIs being sexually transmitted infections. This is an update to the previous legislation that, as I referenced, the General Assembly passed last year. That bill, Senate Bill 84, authorized pharmacists to provide injectable medications to treat chronic needs, conditions, or disorders that did not explicitly include STI injectables. And that's what this bill hopes to do, is to also include STIs. Senate Bill 19 is a simple bill to really add in those provisions. We tried to do this, as you might recall, last year through an amendment as the bill was working its way through our committee. And it was adopted by this committee and adopted by the full Senate, I think, unanimously. Unfortunately, the House did not concur. And so there was a back and forth that occurred during the end of last session with regards to this provision. And unfortunately, this provision did not make it. And so we do appreciate the effort of the chair, Senator Pinsky, during the interim to write a letter to MDH requesting that they address this shortcoming via either an executive order or potentially even clarification in regs. Unfortunately, the Maryland Department of Health did not adopt this provision, nor was the Board of Pharmacy willing to address this in regulation. And so that's why we're back here now before this committee to address this shortcoming in last year's bill that was unfortunately left unaddressed. So let me be clear that we also this was brought to our attention by pharmacists early during the last legislative session as an issue that they would like included into last year's bill. So this was not without merit. This was actually brought to our attention by pharmacists who treat patients that have sexually transmitted infections. Maryland, as a state, has seen a dramatic increase in STIs in recent years. And just in the years from 2010 to 2019, there have been a 51% increase in the total cases of gonorrhea, primary and secondary syphilis, and chlamydia. And when left untreated, these infections cause serious health complications. For example, with syphilis, it can lead to disability, dementia, heart disease, even fetal death. Gonorrhea can cause pelvic inflammatory disease, even infertility and abnormal pregnancies. And these conditions can be readily treated with intramuscular injectable antibiotics. As treatments for STIs has evolved over the past few years, more and more of these options have emerged that do not cause damaging side effects, notably antibiotic resistance, which I know is a issue that has come before this committee as well. These injectable medications make it easier for patients to be able to be cured of their STIs without having to schedule a time-consuming doctor's appointment, and oftentimes are more easy to follow or to adhere to than with oral medication regimens. So, for example, with syphilis, there's a common oral antibiotic that can be used. Many public health agencies now also endorse and administer injectable antibiotics, which my panel will attest to. So while SB 19 will further expand authorization for pharmacists to perform injectable medications, this practice is already common throughout much of the country. Only 3 states in the country prohibit pharmacists from administering injectable medications, with the remaining states permitting varying treatments. Injectable injections, intramuscular injections rather, are already preferred in comparison to oral medications for first-line treatment of gonorrhea. Because of the dosage frequency of oral treatments, there's oftentimes a higher risk of treatment failure, meaning that it's less likely that patients would adhere to the treatment regimen because of the oral treatments that they would need to undergo. And so longer acting injections would reduce the likelihood of further spread of infection to others, also thereby increasing compliance and reducing the likelihood of antibiotic resistance. And so the bill also establishes the framework for which new STI treatment regimens that were recently approved by FDA could also be applied to, and this was just in 2021. There's also cases where individuals may develop neurosyphilis. So if you don't treat syphilis early enough, it progresses in stages through varying degrees of severity. And unfortunately, if it progresses to a point where an individual has neurological symptoms, oftentimes in that instance, you would need maybe up to 14 days of an intramuscular injection of an antibiotic to be able to cure yourself. So it's not as easily cured as if you had the initial localized case of syphilis. And that could also be helped with the ability of pharmacists to be able to administer this. So additionally, during the pandemic, the CDC released updated recommendations for the treatment of STIs that endorsed pharmacists as appropriate and oftentimes more accessible options for patients to receive these injectable treatments. It said that STI clinics may find alternate ways to deliver non-vaccine injectables, such as penicillin and other medications. Where allowed, clinics may want to consider referring these patients to pharmacists for the delivery of these injectables, and that's quoting the CDC. So with that, why don't I go ahead and wrap there? Because this is, I think a part of the statute that this committee is already familiar with. All this bill does is a very simple provision to add STIs as a conditions that pharmacists could also administer maintenance injectables for. So I'd like to thank the committee for the opportunity to present this, and we'll be happy to turn it over to individuals of our sponsor panel who will also be able to add their thoughts to this as well. That's Dr. Hamel from Johns Hopkins, Dr. Gilliams from the Baltimore City Health Department, and Mr. Wakoku from the State National Community Pharmacists Association. Yep. So with that, let me turn it over to Senator Kagan.
Thank you, Senator Lamb. Before we shift to our witnesses, just want to urge you and remind you, colleagues have heard this before, but if you can try to avoid acronyms so that we know what you're talking about, it will make your testimony much more effective. And I just, again, want to remind you, so Mr. Hamel or Dr. Hamel will get 5 minutes on the clock, but the others will get 2.5 minutes. And I see that Senator Riley has a question. Senator, is it okay to wait until after the witnesses? Okay, and just for the record, there is no opposition. So you can keep that in mind when you give your testimony. You're not going to be fighting against anyone who doesn't like this idea. So Matthew Hamel, welcome to EHE. You may begin your testimony.
Thank you very much. Just before I begin, my expectation was that I had 2 minutes and 30 seconds, so I've kept my testimony to that, but it will give more time to answer questions if that's appropriate.
You win bonus points for being briefer than the allotted time, so thank you.
Well, good afternoon, and thank you, Chair Pinsky and Vice Chair Kagan and members of the committee for the opportunity to testify on behalf of SB19. My name is Dr. Matthew Hamel, and I'm testifying in my role as a physician who has specialized in the prevention and treatment of sexually transmitted infections for more than 20 years. As you've heard already from Senator Lamb, sexually transmitted infections are the cause of significant morbidity or disease and can lead to mortality or death, particularly in babies born of pregnant people with syphilis. Sexually transmitted infections are the most common cause of tubal factor infertility, and this is where the fallopian tubes are scarred because of sexually transmitted infections. And this can lead to ectopic pregnancy, where a pregnancy takes place outside of the uterus, which can result in maternal death. Sexually transmitted infections also dramatically increase the risk of transmitting and acquiring HIV infection. Those most at risk of sexually transmitted infections, namely young people, people of color, and sexual and gender minorities, have some of the most insurmountable barriers to accessing STI or sexually transmitted infection treatment. Between 2010 and 2019, rates of early infectious syphilis in Maryland increased by more than 250%. So Maryland is in the grip of an STI epidemic, and the numbers have skyrocketed, as we've heard from Senator Lamb, in the past 5 years. Public health efforts to date have done nothing to dent this. And I would ask you to imagine a scenario where other conditions, such as heart attack or breast cancer diagnosis, doubled in a 5-year period, and the sense of urgency that this would engender. Again, as we've heard, the standard of care for certain sexually transmitted infections, the treatment of certain sexually transmitted infections requires injectable antibiotics. And also the alternative treatment for some infections also require administration of injectable antibiotics. Receiving such treatment from pharmacists, as outlined in SB 19, is important for numerous reasons, some of which I will enumerate. As we've heard, it's common practice. Most states in the United States already do this, and pharmacists are highly skilled at providing other injectable therapies. It increases access for patients, and it goes some way to address the inequities introduced by historic and current structures, such as lack of transportation and barriers to arriving at a brick and mortar clinic. Patient choice is increased, and also receiving treatment in a pharmacy can decrease the stigma of coming to an STD clinic. Pharmacists know their patients well and are trained in emergency management of adverse drug reactions. So with all that said, I would like to thank the committee again for the opportunity to testify today. I'm happy to answer any questions you may have, and I respectfully urge a favorable report on SB 19.
Thank you for your testimony. And this is our first day, so look at Lemuria, so quick. All right, so the next witnesses will each get 2.5 minutes, and we are going to hear next from Elizabeth Gilliams. Ms. Gilliams, welcome.
Good afternoon. Thank you, Chair Pinsky, Vice Chair Kagan, and members of the committee for the opportunity to testify on behalf of SB 19. My name is Elizabeth Gilliams, and I'm testifying on behalf of myself as an infectious diseases physician who specializes in sexually transmitted infections. Like Senator Lamb and Dr. Hamel mentioned, in the last 20 years ago, gonorrhea rates in the US were at historic lows and syphilis was close to elimination. This progress has dissolved in recent years. Now, by Maryland's most recent report on sexually transmitted infections, cases of gonorrhea increased 50%, and primary and secondary syphilis, or early infectious syphilis, increased 253% from 2010 to 2019. Congenital syphilis, which occurs when a woman is infected with syphilis and goes untreated or is inadequately treated and can lead to premature birth, stillbirth, and severe birth defects, has had a near doubling of rates in Maryland in just a few years. Simply put, sexually transmitted infection control is a public health emergency in Maryland. And as Dr. Hamel mentioned, the standard of care for gonorrhea and syphilis requires the administration of specific injectable antibiotics. Those are the guidelines. The alternatives are less effective and not preferred, and those alternatives being oral antibiotics. The ability to receive this treatment from pharmacists, as outlined in SB 19, is important for many reasons. One, many primary care offices do not carry these injectable antibiotics, which creates a barrier to treatment. And during COVID-19, there can be compounded limitations on provider availability. Two, pharmacy access can be more convenient and accessible than a provider office, considering transportation or business hours. Three, pharmacy access can center patient choice. And as Dr. Hamel mentioned, patients can be treated without the barrier of stigma of visiting an STD clinic. And then finally, SB 19 aligns with several states where pharmacists administer injectable antibiotics already. Pharmacists are well prepared to safely manage these injections and the reactions from their experience in administering vaccines and other medications. I'd like to thank the committee again for the opportunity to testify today. Hope I'm under 2 minutes 30. Happy to answer any questions you may have, and I respectfully urge a favorable report on SB 19.
Thank you very much, Ms. Gilliams. You did great. Next up from the National Community Pharmacy Association, Bulawo Akwakoku. Great name. Very cool. Welcome to EHE.
Yes, thank you, Madam Chair, and thank you, members of the committee. My name is Bulawo Akwakoku. I am the State Government Affairs Manager at the National Community Pharmacists Association, NCPA. And our organization represents over almost 20,000 independent community pharmacists across the country, almost 400 in the state of Maryland, and which serviced over about 20 million prescriptions in the state in 2019. And our organization urges a favorable report on SB 19 to expand the authority to administer long-acting injectables. A lot of the points have been reiterated by Liz, by Dr. Lamb, by other members of on my panel. And one thing that I would like to reiterate is access to these treatments. Over 90% of Americans live within 5 miles of a pharmacy, and expanding this authority to pharmacists will increase access a lot as more and more Americans live in very close proximity of pharmacies to achieve get these medications. The pharmacy profession is slowly expanded from just dispensing and fulfilling prescriptions to now having a full and very robust patient and provider relationship between a pharmacist and their patient, which means that pharmacists are not only just seeing them anytime they're coming prescription, but they're also coming in for screening tests, for vaccines, for other forms of tests, and now adding long-acting injectables, which can prove to be elusive when it comes to that sort of treatment for STIs and other chronic conditions. This bill will provide the access and improve healthcare outcomes as well. So I urge the committee and hopefully the full Senate and the General Assembly to pass this bill SB 19. Thank you.
Thank you very much, Mr. Akwakoku. And we have one other witness, Kaylee Locklear. Is Ms. Locklear here? You may begin, and you have 2.5 minutes. Welcome to EHE.
Great. Thanks so much, Madam Vice Chair. For the record, Kaylee Locklear here on behalf of the Maryland Association of Chain Drugstores in support of this bill. I want to thank the chair and the committee for fighting for this inclusion in last year's long-acting injectables legislation. I'll keep my comments short. Pharmacies are the most accessible healthcare provider in Maryland, and consumers do trust highly trained professionals that are behind the counter. Pharmacists have earned a doctorate of pharmacy in a 6-year-long program that's focused on patient assessments, screenings, and direct patient care. They have in-depth knowledge of injectables, preventing medication side effects, and avoiding contraindications, as well as providing emergency care in the case of an adverse reaction. Marylanders trust their pharmacists to understand and administer their medications. It is common sense that STI maintenance medication should be available for administration through their local providers that communities already know and trust. We fully support this legislation and urge a favorable report. Thank you.
Thank you. Colleagues, I just want to flag other testimony has been submitted in writing. As I indicated earlier, it is all favorable. So Free State Justice, the Maryland Academy of Advanced Practice Physicians, the Nurses Association, Board of Pharmacy, and League of Life and Health Insurers. We have a question from Senator Riley. And then
thank you very much, Madam Chair. Dr. Senator Lamb, I have a question for you.
Sure.
Very supportive of the bill. I understand the concept. Share with me who shows up at the pharmacy. Would it be the patient with a diagnosis from a doctor? Or would the pharmacist be required to determine whether it's gonorrhea, syphilis, or any one of the shopping list of issues that might be presented? Where does a diagnosis take place?
That's a good question. Thanks for that. The diagnosis still remains with the doctor or the provider. So that could be a nurse practitioner, a physician's assistant, and whatnot. I think you probably recall from last year's bill that we did, through language there, allow that if the provider, which could be a physician or a nurse practitioner, et cetera, gave written permission for the first dose to be administered by the pharmacist, that the pharmacist could do that locally. So diagnosis still takes place with a licensed provider that's a physician, NP, or physician assistant, but then the administration could take place with a pharmacist.
Thank you, Doctor. Thank you, Senator Lamb. Thank you, Madam.
Thank you, Senator Ellis.
Great. Thank you, Madam Vice Chair. Senator Lamb, thank you for this bill. I know I remember some issues from this bill that came up last year, questions I have. And so Senator Riley did one of my questions. And so let me skip over that. I guess let me talk to Dr. Hamel. So he gave some statistics on STDs and he talked about different groups' propensity for this. And I remember years ago, I read a study that said that analysis is skewed in terms of minorities more likely because of access to healthcare. So because of access to having private physicians and poverty issues, more minorities end up in public clinics who are religious in reporting their numbers, but more affluent white citizens, they go to their private physicians who more times than not do not report and their numbers do not end up in the public system. So I always remember statistics, it's one of those things, right? That it depends on your sources and are they reliable? So is there any action taken on this over the last few years as far as reporting, say private physicians reporting? Are they obliged to report their numbers to the public health authorities?
Thank you, Senator Ellis. I appreciate the question and the opportunity to respond. So it's a legal requirement that certain sexually transmitted infections are reported, and these include the ones that we've discussed this afternoon: syphilis, chlamydia, gonorrhea. And I think that you raised such an important point about access and how statistics can skew things in one way or another. But what I would respectfully submit is that the vast majority of STI diagnosis in the United States and in Maryland specifically are not happening in sexually transmitted infections clinics. They're happening in private physicians' offices, in emergency departments, in urgent care. I would argue that what we're seeing is actually the tip of the iceberg rather than the iceberg under the water. We're generally seeing people who have symptomatic sexually transmitted infections, and we know that upwards of 70% of sexually transmitted infections will have no symptoms whatsoever. And I think that the point about access is, to me, as a practicing physician, is one that is absolutely central, is that we have clinical services that are located in places that are not the most convenient to patients, that we operate during business hours when it's not convenient for patients. We're not a warm and friendly place for parents to bring their children in to, for instance. And all of these things mean that patients lack access for treatment of their healthcare needs, specifically sexually transmitted infections.
Thank you for that, Dr. And one last question, Madam Vice Chair, if I may. So these injectables, I don't know if Dr. Lamb or Dr. Hamel can answer this or anyone else. So where are they administered? What part of the body will they be administered to? Is it the arm and the buttocks, the legs? I'm not sure.
Dr. Young, do you want to take that one? I can answer that too, but go ahead.
Absolutely. Thank you. And thank you, Senator Ellis, for these really thoughtful questions. To get to your first question, the treatment for gonorrhea can be an injection that's administered either the deltoids, the arms, and the muscles. Typically, the treatment for syphilis is injection into the gluteal muscle in the bottom. Many pharmacies, I'm sure as our other colleagues on today will, explain that they have, private rooms for where this kind of administration can take place in a feasible way. I also want to get back to the other question about reporting. I'm testifying on my role today as myself, but I also work at the health department at the sexual health clinic.
Very briefly, if you could.
Yes, the reporting for laboratory testing for gonorrhea and chlamydia is required by both the provider and by the lab. And so with combining both of these elements, the diagnoses are funneled to the health department. And so most often it will be a provider or a lab report that comes in from a private practice, is counted with the total numbers.
Okay. Yeah. And so, Dr. Gilliams, you read my mind where I was going with that question about what parts of the body. And so I go to my local CVS pharmacy in Bryansville, Maryland. I can tell you there are no private areas there for the most private of injection, right? And so I'm kind of trying to choose my words carefully. So we have to look at that. If we are a pharmacy, will be doing these kind of injections at the most private parts. We need to make sure that patients' privacy is really protected.
Of course. Thank you, Senator Ellis.
Thank you.
So the questions are only being asked by senators. We will have an opportunity. The sponsor of the bill will be able to answer additional questions in a voting session. And so you can totally feel free, witnesses, to follow up with anything else. I just have a very quick question for the sponsor. Senator Lamb, I just looked up and there is a House Bill 229 that is being heard later this week, sponsored by Delegate Kay Young. And I just wonder if our problem was that the House and Senate couldn't agree. Can you just give us a sense that we're not going to go on the same sort of lost cause effort again this year? Is the House more amenable this year, or is this bill different than last year?
So the amendment is this. Yeah, I'm muted. The amendment is the same as last year. The issue last year was that while I had introduced this as a concern that had been brought to me by pharmacists, for example, from the panel last year during the hearing, this committee was familiar with that issue already. The contention over on the House side was that it wasn't brought up during the hearing for Delegate Lewis Young's bill. And so it was brought up during the committee markup process, and they didn't feel like they had the ability to weigh in during the hearing. So we are here this year to go through the proper hearing process on both sides.
Got it. Thank you, Senator. I see no other senators' hands up, so that completes the hearing on Senate Bill 19. And the next bill is Senate Bill 37. And it's lovely to have Senator Augustine with us in EHE. And this is jointly being heard with EHE and Finance, and Senator Washington is going to present the bill, and then Senator Augustine, if there's something you want to.
Senator.
Oh, I'm sorry. I'm in the thing. This is an Augustine bill. I'm ahead of myself. Senate Bill 37, Health Occupation State Board of Massage Therapy Examiners requiring license to practice and other revisions. Sorry, it's the next one. I apologize. Senator Augustine, you may begin and tell us about Senate Bill 37.
Thank you so much, Vice Chair Kagan and members of the committee. Senator Malcolm Augustine here asking for a favorable report on Senate Bill 37 that modifies the Massage Therapy Board. It provides transparency by publicizing those who are licensed. It simplifies the licensure structure, updates practice settings and licensure education requirements, and it puts us more in line with the national standard for massage therapy licensing, and will allow the board to join a national professional compact, creating great license mobility and access to more qualified providers. Now, this legislation was developed with the board and the Maryland chapter of the American Massage Therapy Association working together. Colleagues, at this point, Maryland is the only state with a bifurcated license scheme that requires a college degree to become a licensed massage therapist. This legislation will fix that. The bifurcated licensed massage therapist and registered massage practitioner structure has turned into an uneven application of the practice. Further, the college credit requirement is not applicable for most entry-level positions. So while the single tier proposal eliminates that, at the same time, it increases the educational hours to 750 from 600, which will provide for a robust and complete entry-level education with an emphasis on hands-on education. Massage therapy education and state licensing requirements protects the public by requiring minimum standards. The national average for entry-level education in the United States hovers around 650 hours, while an associate's degree, which does have like 60 college credits, adds at least 900 hours of additional education requirements that are largely not applicable to the profession. This single tier will provide more equity for future massage therapists to be able to attend a trade school or community college program with no further burden of time or expense for college credits. This seems like reasonable as the industry has a median income of $29,000 a year. The current system has real disparities in it. The registered massage practitioners have not been allowed to work in healthcare settings, such as chiropractors' offices, even when they had the same education and often more advanced training experience than, let's say, a licensed massage therapist. There is evidence that this has depressed the income opportunities for registered massage practitioners. To sit on Maryland's Board of Massage Therapy Examiners, one must be a licensed massage therapist, barring over 1,500 registered massage practitioners from eligibility. Maryland's arcane licensing standards have also made portability into the state difficult and confusing, which is another barrier for the general public and military spouses for employment as massage therapists. Like so many other industries, the massage therapy industry has seen a reduction in its workforce. And with significant job opportunities at almost all the massage businesses in Maryland, there really is a gap and really could use more people to fill it. Now, this legislation helps to address those barriers. This will require, but it does so with a transition, okay, from these bifurcated licensure to a single licensure. The Massage Board provided a preliminary roadmap for that regulation that will convert current registered massage practitioners to licensed massage therapists status over the next few years, in essence, grandfathering, if you will, registered massage practitioners. The good news is that it was thoughtfully put together to not create an additional burden of time or expense on any current registered massage practitioner without compromising the new unified license. There are a couple of letters of support that did include some questions about grandfathering of the registered massage therapists, massage practitioners, but as I just previously mentioned, there is grandfathering in the bill. On page 3, lines 11 through 18 deal with just that, just so that you know, where it does provide an opportunity for those in a legacy position, a deadline of October of 2026 in order to make this transition. And finally, we do have a technical sponsor amendment in that it was pointed out to us that and to the board before that we needed to change to a more inclusive term, post-secondary versus higher education. And that was done on page 4, lines 7 to 9. So with that, Vice Chair Kagan and members of the committee, I request a favorable report as amended. Thank you.
Thank you, Senator Augustine. We have 3 witnesses. The first witness will get 5 minutes, and that is Caitlin Thompson from the Maryland State Board of Massage Therapy Examiners. Welcome, Ms. Thompson. You may begin.
Thank you so much, Senator Kagan, and thank you very much, Senator Augustine. Good afternoon, committee. My name is Caitlin Thompson, and I am the chair of the Maryland State Board of Massage Therapy Examiners. Thank you so much to this committee for your consideration of SB 37. We hope you will have a favorable opinion. As Senator Augustine has already said, we currently have 2 tiers of massage professionals in Maryland. The primary focus of this bill is to eliminate the designation of registered massage practitioner, which would create a single tier of licensed massage therapist. The changes represented in this bill are the product of years of collaborative effort between this massage board, our professional associations, educators, and our current licensees and registrants. There is only one other state in the US that has a multi-tiered license system. All other states have a single designation for their massage licensees. Working with a 2-tiered system is not ideal. It has been confusing even for those of us who have long been in the massage profession, much more so for the consumer public and potential employers, which creates a safety concern. I would venture that the overwhelming majority of the public is not aware that there are currently different levels of massage professionals in Maryland, and that one currently has a much higher educational requirement. In eliminating the designation of registered massage practitioner and standardizing the educational requirements for all people who practice massage in Maryland, we are creating a safer environment for the consumer public and a more equitable structure for applicants as well as employers. By streamlining our license to a single tier, we allow more portability and ease for out-of-state applicants, including military spouses. This bill represents a large progressive change, and the strategic planning of it has been a multi-year process. This massage board has worked in partnership with many stakeholders, including our current licensees and registrants, trade associations, schools, and national organizations. Part of the process of this bill will require registered massage practitioners to convert to the redefined LMT status prior to October of 2026. We have had an ongoing collaborative conversation with stakeholders to ensure that this conversion won't be an onerous burden to RMPs, either financially or time-wise. Our board has already approved 3 paths to allow RMPs to convert without any additional expense, so that registered massage practitioners will have a fair, accessible, and equitable path from RMP to LMT.
Thompson, could I interrupt you and ask you to translate RNP, please?
I'm sorry. Yeah, that's the registered massage practitioner.
Thank you.
That's the, yeah, and I'm sorry, LMT is licensed massage therapist. So after the conversion, we will only have licensed massage therapists. We believe that this bill will improve the quality of massage therapy in Maryland while making the profession much more accessible to a larger percentage of our population. We firmly believe in this bill and have received overwhelming support. We hope the committee will have a favorable opinion. Thank you again, and I'm happy to answer any questions. Thank you.
Thank you, Ms. Thompson. Appreciate your testimony. I was hearing LNP, like licensed nurse practitioner, which was confusing me. All right, appreciate it. Next is Sharon Oliver, also from the Maryland Boards of Massage Therapy and Chiropractic Examiners.
And thank you very much, everyone. Thank you very much, everyone. I'm actually here to answer any questions that may be posed on behalf of the board.
Okay, well, thank you, Ms. Oliver. Do you want to add any testimony?
What I would love to say is that having joined the board in 2019, I have witnessed the collaborative effort by everyone to ensure that we could transition from a 2-tier system to a single-tier system. The board has worked diligently, and they have considered all possible angles to ensure that individuals have the opportunity to enter this profession with very little, if any, barriers at all to enter in here. And we are very proud of the work that they have done and believe that this will help the state of Maryland to attract individuals from various states.
Thank you, Ms. Oliver. And you have a beautiful accent. Is it Jamaica?
Yes, it is. Thank you.
Wonderful. Well, my predecessor as vice chair was a very proud Jamaican American. So we love her dearly.
Thank you.
So Amelia Mitchell from the American Massage Therapy Associations. Ms. Mitchell, yes, I see you. You may begin your testimony. Welcome.
Thank you, Vice Chair Kagan and everybody. I am Amelia Mitchell. I'm representing the Maryland chapter of the American Massage Therapy Association, and I've been a licensed massage therapist in Maryland for 15 years. Integrating high standards for entry-level massage education into a fair and balanced licensing system is achieved by this bill, and we're asking for a favorable report for SB 37. Raising the educational requirement to 750 hours provides a vigorous and complete entry-level education that will create qualified, ethical professionals. This is how we protect the public. The two tiers have not worked. They create employment disparity and confusion. RMPs, often more qualified than licensed massage therapists, can't work in the same place. It has depressed their income opportunities and creates confusion for everybody. The whole issue of license portability has been problematic. Let's remove another barrier to working in Maryland. And as Senator Augustine mentioned, a point of equity, there are 1,500 RMPs, registered massage practitioners, who cannot sit on the board. The board is strengthened by a diverse group of members and perspectives. The conversion of current RMPs to licensed massage therapists has always been a focus. Our Maryland chapter finds the proposed regulations fair, and importantly, that no RMP be required to get additional education or incur additional expenses as they become an LMT. We urge the board to continue their transparency so all know what to expect. This change will build strength for our industry, and it is time to remove the obstacles to licensure and create an equitable system that allows the needed and valuable massage therapy industry to thrive in Maryland. Thank you. And of course, I'd be happy to answer questions.
Thank you very much, Ms. Mitchell. Next, our last witness, oral witness is Kirsten Bodnerchuk. Welcome, Ms. Bodnerchuk. Are you here?
Thank you. Yes, I'm here.
Hi.
Good afternoon. Thank you so much for allowing me the time to speak on this bill. My name is Kirsten Bodnerchuk. I'm a licensed massage therapist, small business owner, and the vice chair of the Maryland Board of Massage Therapy Examiners. I'm here today to provide testimony in support of Bill 37. As a massage therapist for over 20 years, I've worked in a lot of different facets of the profession. I've been an educator, I've worked in health clinics, on-site and home spas, and I currently own my own clinic. The increase in education hours in this bill will maintain the standard of massage therapy while removing the burden of having LMTs graduate from a college program. While this was previously used to differentiate between the two groups of registered massage practitioners and licensed massage therapists, this didn't necessarily mean that the care was any different nor better with a college diploma. Removing the criterion from our qualifications means we can have a more equitable and accessible licensing process for the residents of Maryland, as well as anyone out of state looking to move into Maryland. Before the board made our final adjustments to this bill, we polled our licensed and registered massage therapists and asked for their input. We asked if they would like to see the hour requirement become higher, and 83% of those who responded said they would like to see the requirements set to 750 or higher. 75% of those who responded said they would like to see college credits removed. And at our stakeholders meeting, we found that we had support from the AMTA as well as several other schools and colleges. This change in the statute will help increase this skill set for future massage therapists right at the school level. This change will maintain national standards as well as increase accessibility to those looking to make massage therapy their lifelong career. I thank you for your time and opportunity to speak, and I hope you have a favorable opinion on this bill. Thank you.
Thank you, Ms. Bodnerchuk. Questions from colleagues? Senator Washington.
Thank you, Madam Chair. Thank you all. Thank you, Senator Augustine, for this bill. I long believed that body work, body manipulation is an important healthcare, part of our healthcare system. I look forward to when more insurance covers a more range of it. But I had a question about distinctions made in general in the practice. So when I think about massage, there are these franchises, and my mother had one monthly. I've done that. And it's not clear to me, are there differences? Is this two-tier system? Does it incorporate sort of these franchise situations, or is it just a practice that is set up by an individual massage therapist, perhaps in collaboration with a physician? Just help me, Senator, better understand, I guess, the business or the field, and how this bill is affecting that.
Thank you, Chair. Thank you, Senator Washington. I'm going to actually ask the folks who are in there to do that. And they please, any one of the three of you, perhaps Ms. Thompson, you can answer that.
Absolutely. Senator Washington, is your question whether or not we have both licensed massage therapists and registered massage practitioners working within chains?
Well, it's just trying to understand the differences. So for example, when I look, I don't necessarily, in some of these, I don't see these are licensed massage therapists. And, but if I go to someone associated with my physician or a freestanding practice, that is more prominent. So I'm just wondering, are there people currently practicing what's called massage or body work that aren't licensed, or does everyone have to have, placing their hands on the bodies, delivering what is called massage? I'm trying to be careful because I really don't know exactly how you deal with it. I'm just a customer. So what are we dealing with in this practice? I see Ms. Bodnerchuk Kristen is nodding her head, so maybe someone can help me.
Yeah, absolutely. I'm happy to, I don't have Kristen on my screen. I'm happy to turn that over to Kirsten. I would say that at the moment the only designation, the difference that you would see is that an RMP is allowed to work in what is defined as a healthcare setting, and an LMT is allowed to work in a healthcare setting and an RMP is not. So I think it's a great question and really helps to identify some of the problems that we're facing in terms of how does the public identify the level of education that their massage therapists. At the moment, if you are practicing massage, you are required to have a license to do so. But Kirsten or Sharon, did either one of you want to respond to the senator's questions?
Yeah, I would like to just add that the question itself, Senator Washington, you're highlighting the very issue that we are trying to address with this bill, which is it's unclear who you're having work on you. If you are getting massage or body work, it should be from a licensed individual. Anyone who is not licensed is not practicing legally in the state. So by setting it to a single tier, that should clarify a little bit of confusion just in that setting. And then with the increased education requirements, we'll be able to further train students at the school level to be able to provide more healthcare.
Okay, and just one more follow up if I could. Currently, is it a situation where you can have sort of one person who, because we have this in some other settings, who is the actual licensee, and that you can have individuals underneath you working who are not licensees? I have seen that in physical therapy.
That is
settings.
excellent question. We do not have that for massage.
Great.
And you are not allowed to work underneath someone else's license or registration in Maryland.
Great.
That's an excellent question. Thank you, Senator.
Great. Thank you. Thank you so much. Thank you, Madam Chair.
Thank
And again,
you,
thank you for
Senator.
this bill.
Thank you, Senator Washington. Senator Simon Air.
Yes, thank you. Interesting topic. So, and I'm not an expert on this, but the current system, I believe you had the one side that dealt with the massage and all the muscles and the skeletal and all that, and they learned all that. And then you had the LMT who had some additional education so they could work in a healthcare facility like a chiropractor. Maybe I'm getting the terms backed up, but I guess my question is, what is this 150 hours extra educational requirement put on, in the sense that currently they're being trained, they seem like they're doing an excellent job, unless you can let me know if they're not. Whereas the LMT was getting some additional education, but it wasn't related to massage. And I thought that was the issue. So why are we increasing their educational hours by 25% when that didn't seem to be the main issue?
By removing the college requirement and increasing the hours in massage therapy, which is not an equivalency. So the college that we are taking away is not equivalent in terms of hours to what we are replacing it with. We're able to have a much more specified massage therapy education that reflects more along the lines of the national standard.
So you say taking away the college experience. So example, in my county, Anne Arundel County Community College has a program. Is that still going to be in existence? You're saying you're taking away the college portion, or?
Yeah, that's actually my massage alma mater. So community college programs that I know BCCC has amended theirs to become a non-credit course. They'll still be offering massage therapy.
So just explain that a little to me, because I know there's a lot goes into it. I mean, it's not just go and rub somebody's back. I mean, it's a lot of training and all that. So explain to me what you're doing. Are they not going to have the learning of the muscles and all that? I mean, explain the transition process not to be a college.
Absolutely. It's a great question. I see my executive director's hand is raised. So I am going to let Sharon Oliver answer the question for you, Senator.
And may I just remind you all that there was no opposition to this bill?
Yeah.
Be really brief.
And
I
Senator,
have, yes.
Senator, thank you. Senator Simon Air, I also would just say that if you look in the bill, it still indicates the areas that are more specific to massage. And so instead of certain requirements, let's say for like math and things like that, it emphasizes, pathology, health and hygiene, and then supervision with on-hands technique. It's trying to be actually more focused on what's required to be able to do this position, including those kinds of educational aspects that you were talking about. The other thing that I just didn't get a chance with Senator Washington, this bill also, we just didn't mention this, it does increase the fine up to $50,000 now for people who are out there who are providing massage who are not licensed, because that is a problem. And so that's also part of what this bill does. It does do that so that, and then of course, as I mentioned in the beginning, we're also going to make sure that that is published as well, those people who are licensed, to protect the public. So that was all part of what went into this bill.
Okay. And I know there was no written opposition, but I like to understand the bill. So for people who have a license now, either or, you said they have, I think, until 2026 to transition at no cost or no additional education. Can you just explain what that means for a person that's out there that has a license? What do they have to go through if it's no cost and no additional education to transition? Is it just fill out a form, or what do they have to do?
a great question. So our board has already voted to approve 3 different paths to conversion from RMP to LMT. And again, this wouldn't go into effect until October 31st, 2006. The first path is a legacy path for anyone who has been licensed for 10 years or more. And there is nothing that you need to do in that option to become to go from a registered massage practitioner to a licensed massage therapist at that point in time. And more than half of our current registered massage practitioners will qualify for that option. The second option is a work experience option. So if you have 1,000 hours of work experience within 2 years, you will qualify. And the third is based on hours, which we have already continuing education requirements every 2 years. And for the most part, most people will qualify for that option. If you haven't already qualified for the first 2, which will be the majority of our massage practitioners, then you'll be able to do it through hours. So we've outlined a way for everyone to continue to get education and experience, which we believe will make them better practitioners and therapists.
Yeah. Okay, and last question, and we can discuss some of that in our bill hearing. The penalty, I noticed you talked about increasing that. And I had it briefly, I just read over it. It seems like the current law says you can go after them criminally and you can get some time in jail and a fine. And then this is putting on top of that, up to $50,000 on top of the fine and the jail sentence. And that, I guess the question is, how many are you prosecuting at this time? And is that what you feel, that you're not getting them strong enough penalties, and that's why you wanted the additional 50,000?
I'll answer that question for you.
Thank you,
So
Sharon.
you're welcome. At this time, the board does not have the authority to prosecute anyone who is practicing without a license. As a matter of fact, that's considered a misdemeanor, and we have not had any cases thus far. The civil penalty that has been proposed in this bill is in line with the civil penalty that is across most, if not all, of the other health occupations board. So when we receive information that an individual is practicing without a license, we really have no teeth, nothing with which to act as a deterrent for these individuals. So that is the reason that.
So I'm not a proponent of, you should go after them, and I appreciate you doing that. But you're talking about civil. So you're saying that you have not prosecuted any or put out for prosecution anybody, because you currently have the ability to go after them and give them a fine and put them in jail and things like that. And
no, all we can do at this stage is refer it to local law enforcement. This is a low-hanging fruit for local law enforcement.
Have you referred them to local authorities?
We have referred several cases. Since I've been there since 2019, we have referred several cases. And unless the individuals are involved in something like prostitution, law enforcement takes no action.
Okay, so they're just not prosecuting?
No.
Okay, all right, thank you.
You're welcome.
Thank you, Senator Simon Air, for your questions. Before we move forward, there is someone in the room that has a number rather than a name. I'm going to ask you please to go up to the upper right corner of your own Zoom box and click rename, or we will seek to remove you from the Zoom room. We need to know who's in the room so we don't have problems in our hearings. So again, who is in as a number, and Lemoria Stanton, our counsel has, our staff has tried to contact you through chat. So now I have to do it out loud. So if you could please do that.
Oh, I'm sorry. This is Karen Evans from the Board of Nursing. I'll do that right now.
Thank you, Karen. We appreciate that. Very quick questions. I have a quick one, and Senator Ellis then, but we have a lot more bills today, folks. So my quick question, which I know we will be asked about on the floor, following on Senator Simon Air, going from 600 hours to 750 hours, can you just talk about the implications for tuition costs, since we want to make sure that we have a diverse student body, including those who may be stretching to afford tuition? What are we looking at in terms of how long that'll take, is that an extra semester or whatever, as well as how much might that cost someone. Thank you. And I'll toss it to Ms. Oliver since you seem to be really good at some of the details, but anyone can answer. Thank you. You will need to unmute yourself though.
Okay, so I can address it from the community college standpoint at this moment. So anyone who's attending the community college will no longer have to take the additional 24 hours of credits, 24 credits in basic and applied science. So that could reduce the amount that those individuals will be paying to complete a program at the community college level. Most of the schools so far have adapted their program or have indicated they will be adapting their program to combine those hours. They have not specified what, if any, additional costs would be involved. And as a matter of fact, many of the schools already have programs that require 620 or more hours. There are some that have 700 or 800 hours. So they should be able to adapt to this new standard very easily without really incurring costs, additional costs to these students.
Okay, so Senator Augustine or Ms. Oliver, anyone, before we get to the Senate floor, if this bill does move out of committee, that is the sort of question we might be asked on the floor. So I'd love to have answers to that.
Vice Chair Kagan, the expectation is that we are actually removing costs, okay, because they do not have to go
to the 24
college degree, the college credits and everything else. It's much more of an emphasis of time when they are, you know, where they don't have to go and get that. That was part of the intention of the move. While the hours look different, the credits had a certain cost associated with them that cost more than would be the case with the hours. Okay.
Really appreciate that. Thank you, Senator Augustine. Appreciate it. And wrapping this up will be Senator Ellis.
Yeah, thank you, Madam Vice Chair and Senator Augustine. Look forward to moving this bill through. Good bill. Thank you so much. I would like to refer to a comment made by my distinguished Vice Chair in mentioning Senator Nathan Pulliam and from Jamaica. I just want to say to Ms. Oliver that I too was born in a place called Port Antonio, and Senator Nathan Pulliam always taught me to always ask a question. So the question is, where were you born?
Okay, I will say I was born in Kingston, but I claim Maypen as home because I attended high school in Maypen, and that for my lifelong friends and friendships were formed there.
Okay, wonderful. Good to meet you virtually.
Same here. Thank you.
Senator Ellis, that for once was not an "isn't that so" question.
No, it's actually a real question. Good point, Mr. Chairman.
Thank you.
So we have Senator Nathan Pulliam in our hearts and in our minds as she's recovering from a health challenge. That completes the hearing on Senate Bill 37. Thank you, Senator Augustine. I do need to go back for just a micro moment to Senate Bill 19. I erroneously indicated that the League of Life and Health Insurers were in favor of the bill. They are not. They were unfavorable. So the committee can consider that when we consider the bill. And I apologize for anything that might have been misleading in that. The next bill is Senate Bill 62, Senator Washington. And this is the one where we are delighted to have Senator Augustine with us. And it is a big fat folder. So I know we're going to learn a lot about the cessation of tobacco product use. So welcome, Senator Augustine. And as always, it's great to have Senator Washington in her own committee. You all may begin.
Thank you. Thank you so much, Madam Chair. For the record, Senator Mary Washington presenting SB 62, a pharmacist aid cessation of tobacco product use. Colleagues, as written, SB 62 was passed unanimously on the Senate floor in 2020. It was referred to HDO But due to the pandemic, the bill did not get a hearing. So this bill has a 3-year history. It's been through revisions based on feedback from past hearings and from organizations who have been both for it and in opposition to how it was originally drafted. So SB 62 is really an important step towards expanding access to care for Marylanders by continuing to engage pharmacists in our efforts to improve the health of our communities. We've been hearing bills about that today. And certainly COVID-19 pandemic has made it even more urgent that the need for collaboration and teamwork in the delivery of life-saving medications and vaccines should be our top priority. So SB 62 would grant nicotine replacement therapy prescribing and dispensing rights to qualifying pharmacists. The bill would do 3 things. First, qualifying pharmacists would have an opportunity to, or would be required to document newly prescribed medication in the electronic medical record. They would need to refer the patient to a primary care practitioner for treatment and require the pharmacist to undergo, this bill also requires pharmacists to undergo training set by the Board of Pharmacy. So we know already that addiction to nicotine costs lives and it costs precious state care health care dollars. Maryland spends $2.7 billion annually to manage healthcare costs of smokers. That data is from 2018. It has done nothing but increase. So each year we're spending billions of dollars treating individuals for a preventable disease and preventable diseases that are related to smoking. So we can both improve the healthcare of our constituents. We can also decrease annual tax dollar expenditures substantially if we create easy, accessible ways to get smoking cessation aids into the hands of our smokers. So we know that about 11% of Marylanders identified as active smokers. And this number is probably an underestimate because rarely, or some percentage of people don't own up to this. But in 2021, there was a survey and it said that about 11% of Marylanders identified as smokers. And we also know that smoking is the leading cause of preventable death in our country. In fact, in Maryland, smoking causes more deaths than homicide, suicide, HIV/AIDS, drug overdose, and accidents combined. So this should be our number one effort. It should be our number one cause to rid our state of this preventable disease. So fortunately, though, Maryland current law does cover tobacco cessation medication and services offered by licensed healthcare practitioners. This is great. But SB 62 would simply extend those same provisions to licensed pharmacists in Maryland. And it would, again, this is a medication that is approved by the U.S. Food and Drug Administration. This bill makes fiscal sense for our constituents also. Not just for the state of Maryland, because there are already over-the-counter options for nicotine replacement therapies that are available for purchase. It's just insurance companies just don't cover these. So this financial barrier really prohibits some patients from purchasing these products. For example, a 2-week supply of patches can cost anywhere between $30 and $45, while a pack of cigarettes is about $7. So SB 62 would allow most patients to get nicotine replacement therapies with a $0 copay. The goal here is to make it as easy as possible to get nicotine replacement therapies into the hands of smokers with as few barriers as possible. The CDC authorizing pharmacists to provide tobacco cessation is safe. And the CDC has stated that the use of most of these medications is appropriate for most adult smokers. In fact, 15 states have passed legislation to allow pharmacists to prescribe these products. Arizona, Arkansas, California, Colorado, Indiana, Iowa, Maine. So a mixture, North Dakota and West Virginia. So there's a mixture of states that have approved this type of legislation. So colleagues, I respectfully request your favorable report. I have 3 members of my panel. It'll be the lead proponent is Dr. Seth Martin. A second is Dr. Bildowski, representing herself as pharmacist, and also Blair Innes, an attorney representing himself. Thank you so much, and we'll be willing to answer questions after these 3 panelists have shared their thoughts and insights.
Thank you, Senator Washington. I have to say just for a moment that when I was in the House of Delegates in the 90s, I sponsored a bill requiring that insurance cover the patch. So just before its time, long time ago. So Dr. Seth Martin from Johns Hopkins Medicine, welcome to EHE. You may begin your testimony.
Thank you very much. I appreciate it.
I'm sorry, Dr. Martin, before you start, let me just indicate that there is unfavorable testimony on this bill. So, but you have 5 minutes. Go ahead.
Thank you so much. Yeah, I'd be very curious to learn more what the concerns would be, because from the physician cardiologist perspective, I think this is a no-brainer. This is really, I think, a win-win all around. So, as you know, I'll try to keep it brief. I mean, I think it's already been stated how critical a problem this is, but just to reinforce some of the points, so more than 10%, more than 1 in 10 Marylanders currently use tobacco products, and many of these, the majority have tried to quit, and it's a struggle to quit. And as a cardiologist, I see the devastation that causes in terms of people coming in with heart attacks and, suffering, and their families suffering as a result of this. And from an economic standpoint, this is just huge. The Maryland Department of Health estimating 2.7 billion in state costs. So when it comes to pharmacists, again, I'm a physician, I'm a cardiologist. Pharmacists are absolutely critical members of our care teams. And by this legislation basically is about opening access to the talents of pharmacists to help prescribe these critical therapies. And I'm all for this. This is very consistent with many other aspects of the way we practice medicine and cardiology. And frankly, we need more legislation like this that opens up more access beyond physicians to other talented health professionals like pharmacists. And I think it's already been noted, this has been done in a number of other states, and I'm proud to be a Marylander and live in a state that's very progressive. I think it's time we move forward. So I am 100% in support of this legislation as a physician, as a cardiologist. Thank you so much for your time.
Thank you, Dr. Martin. Good afternoon, members of the committee. My name is Catherine Brodowski, and I am a clinical pharmacy specialist in oncology. I'm at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Bayview Medical Center. I'm also a panelist on the National Comprehensive Cancer Network's Smoking Cessation Guideline. And I give this testimony as a resident and practicing pharmacist in Maryland. I'm not representing the views or position of Johns Hopkins Medicine or the National Comprehensive Cancer Network. I am in favor of having increased access to smoking cessation services and decreasing the out-of-pocket costs to preventative care services to populations that are disproportionately impacted. You will hear key themes throughout our testimony today: increased access to care for Marylanders, impact to public health, barriers to smoking cessation, and pharmacists' extensive training and skill sets. Actually, I was reading in 1999 that there was a report that to the governor entitled "Making Maryland a Tobacco-Free State," which set key goals around a single vision. Maryland will lead the nation in tobacco use prevention, control, and cessation. And their primary goal was a 50% decrease in the adult tobacco use by the year of 2010. And in 1998, that benchmark was 22.4%. Well, we finally hit our goal of decreasing by 50% in 2021, where we now have 11% active smokers in Maryland. Our methods of smoking cessation delivery have changed very little over the past 23 years, and I think it's about time that we start increasing the access to care for these patients and change those methods of delivery now. Pharmacists are well positioned in the community and trained during their doctorate degree in motivational interviewing and counseling techniques, as well as medication experts. The National Comprehensive Cancer Network and American College of Cardiology recognize pharmacists in their guidelines as essential members of the tobacco treatment team. And by allowing pharmacists to spearhead this effort, other providers can focus their finite appointment times on more acute issues or hearing pressing patient concerns. When we spread some of these clinical responsibilities amongst healthcare roles and empower them to work at the top of their license, we can support one another, and most importantly, we can best support the patient. I hope that this committee provides a favorable report for SB 62. Thank you.
Thank you, Dr. Brodowski. Appreciate your presence here. And Blair Innes is Senator Washington's third witness. Ms. Innes, welcome to EHE.
Thank you. Good afternoon. My name is Blair Innes, and I'm the Senior Staff Attorney at the Legal Resource Center for Public Health Policy, testifying in my individual capacity in support of Senate Bill 62. I first want to reiterate what Senator Washington says. We've heard from the opposition repeatedly over the years that the primary care provider should be assessing the risk of a person using nicotine replacement therapy before dispensing the medication. I want to be clear, we are talking about over-the-counter therapies, which the National Cancer Institute states on their website, smokefree.gov, that nicotine replacement therapy has been available for more than 30 years. A great deal of research has been done. The research shows that nicotine replacement therapy is safe and effective for almost all adults for quitting smoking. For most people, there's no need to talk to a doctor or healthcare provider before using nicotine replacement therapy. So the benefits of unencumbered access to nicotine replacement therapy far outweighs the risks. Health equity is a long-standing core value of public health and is one of the goals listed in the Healthy People 2030 framework. COVID-19 has shown that we need more action around health equity, and pharmacies have been a part of the solution. The scope of practice of pharmacists has been expanded, as we know, and the Centers for Disease Control and Prevention reported on September 23rd, 2021, that over 70% of current COVID-19 vaccine administration is occurring in pharmacies. But even before the COVID-19 pandemic, pharmacies have committed to leveraging their convenience as far as access and trust accessibility and trust in the community to break down access barriers and promote health equity. Pharmacies have increasingly provided enhanced access to things like routine vaccinations, screening and testing for conditions including HIV and hepatitis C, chronic care management for diabetes and cardiovascular disease, support for behavioral health conditions, and many more. Pharmacists have always been ready to do more and are so often overlooked until the country's in the midst of a catastrophe. We saw that in 2009 during the H1N1 outbreak, when the pharmacist scope of practice at that time was expanded to administer the vaccine, and most recently during COVID-19. And every time they have been an integral part of the solution. Lowering the number of tobacco-related deaths in Maryland is no exception. Passing Senate Bill 62 is a sound public health decision. Thank you.
Thank you, Ms. Innes. Right on time. We still have a whole bunch more witnesses. So as the chairman often says, please be additive and don't read from your testimony. But if you could tell us why you think this bill is important, that would be great. The next witness is testifying for herself as a private citizen, Bobby Nguyen. Welcome to EHE.
Thank you, Senator Kagan, and good afternoon, committee members. My name is Bobby Nguyen, and I'm a second-year cardiology pharmacy resident at the University of Maryland School of Pharmacy. I'm speaking in support of Bill 62 that increases access to nicotine replacement therapy in a cost-effective manner to patients who need it most. Opponents of this bill may question the level of training that a pharmacist has to be able to assess and recommend the appropriate nicotine replacement therapy for patients. So I'm speaking to provide committee members with the context of the level of training a pharmacist pharmacist undergoes. So as mentioned previously, I'm a second-year cardiology pharmacy resident. This means that I've completed 4 years of pharmacy school, and I'm at the tail end of 2 years of additional clinical training that takes place primarily in a hospital setting, where I regularly participate in multidisciplinary teams. The American Association of Colleges of Pharmacy, which accredits all schools of pharmacy, state that all new pharmacy graduates at a minimum are required to be able to independently measure vital signs, develop a treatment plan with the patient and provide education, and determine monitoring parameters to assess the safety and efficacy of a treatment regimen. So in the context of recommending nicotine replacement therapy, this is far encompassing. Throughout pharmacy school and now as a pharmacy resident, I've spoken with countless patients about smoking cessation and their willingness to quit. And more often than not, my patients tell me that they want to quit, but they've been unsuccessful in the past. The Center for Disease Control suggests that patients may need anywhere from 8 to 11 quit attempts before being successful in permanently quitting. So it can be really exhausting, as you can imagine, to feel like you failed at quitting something even after the first try. And that's why it's so important for patients to have access to a member of the healthcare team, such as the pharmacists, which you've heard in an earlier bill, are often heralded as being the most accessible team member who can not only help them choose the correct therapies, but also follow up with them regularly. Not to mention something that Senator Washington had mentioned in her opening speech, that the cost of these patients having to purchase nicotine replacement therapy over the span of 10 or 11 quit attempts can really add up and ultimately serve as a barrier to quitting in itself. So I urge you committee members to consider these points and join us in supporting Bill 62. Thank you.
Thank you, Ms. Nguyen. Thank you for your testimony. The next private person joining us with her opinion is Meredith Sylvester. Welcome, Ms. Sylvester.
Thank you so much for your time today. Hi, my name is Meredith Sylvester, and I'm a Doctor of Pharmacy candidate 2022 at Shannon University School of Pharmacy, testifying as a private citizen. These opinions are my own and do not necessarily reflect the views of the university. As part of my experiential education rotations, I have assessed, treated, and counseled over 80 patients for smoking cessation under the guidance of my pharmacist preceptor. Smoking cessation is not clinically difficult in comparison to other pharmacotherapeutic topics in standard accredited pharmacy schools like infectious diseases, oncology, or psychiatry. In the eyes of patients, it is a critical challenge that needs ongoing, consistent support. It is logistically and mentally difficult to navigate. This bill addresses pharmacists prescribing nicotine replacement therapy. There are 5 FDA-approved nicotine replacement therapy products: the patch, gum, lozenge, nasal spray, and inhaler. The efficacy is directly tied to proper administration technique and repeated counseling. While these products seem intuitive to most, many patients claim that one or more nicotine replacement therapy doesn't work for them because of incorrect use. Time to nicotine replacement therapy in hand is also crucial for patients who gather the motivation to quit. I had a specific encounter with a patient that had smoked for many years and had multiple quit attempts, but was looking for direction on help on what to do. I counseled the patient on different options available and came up with a care plan. The patient experienced delays with the signing of their pending prescription, and a one-day process quickly turned into a 2-week cycle, all while the patient continued to smoke. This is a clear example of a patient motivated to quit and would have benefited from a pharmacist prescribing smoking cessation aids. Pharmacists are trained to recognize the fine details. We improve successful quit attempts by troubleshooting adherence or administration challenges and provide education and motivation to patients about the benefits of quitting. Having pharmacists specially trained in the counseling and education of these products and allowing for the prescribing of tobacco cessation aids is a natural role and responsibility that pharmacists would assume to help the people that need it most. Small changes can make a big impact. Thank you for your time today.
Thank you very much, Ms. Sylvester. The next 3 witnesses are all favorable with amendments. If you could please make it clear what in the bill you believe should be modified when we debate and vote. Leading off is coming back with us is Balawo Akwakoku from the National Community Pharmacy Association. Are you still in the room? All right, let's skip. We'll go to Scott Weber, Vaping Awareness Public Education Society. Scott, welcome to EHE. Good to see you.
Thank you, distinguished Madam Chair, attending chairs, and members of these joint committees. My name is Scott Weber. I'm a co-founder, along with my son, of the Vaping Awareness Public Education Society, which is a nonprofit public health advocacy organization that's spearheading the fight to break cigarette addiction, recognized in our logo. There is no question that smoking is the most deadly, costly, harmful habit known to humankind. I would add to Senator Washington's context of the grim nature of it to say that it's actually twice as deadly as COVID. So she can add that to her list of mentions. And it's not to minimize the tragedy of these other causes, but just to put it into perspective, how harmful it is. So accordingly, anything that can be done to reduce smoking is beneficial to the general public welfare. In that context, SB 62 is welcome legislation. It gets our full support for everything it contains. It's, however, what it's missing is where our concerns. And if you pay attention, or if you our written testimony outlines the areas, but essentially we don't think it does enough. We'd like to have the Maryland Department of Health develop a comprehensive resource center that can be used by these pharmacists rather than they're having to do it on their own. We'd like to require that any of these prescribers engage in quit smoking activities make available to the patient a broad array of quit smoking information that it's included, but it's not limited to the NRT that is talked about. NRT, nicotine replacement therapy, is only one that is prescribed. In fact, it's actually, when you add on to it options such as Chantix and Zyban, those are critical elements that are a component of a stop smoking process as opposed to just a nicotine replacement therapy. Most NRT is actually available without a prescription, so we want to make sure that they get the attention of a pharmacist. But we also want to add into this other options, including NRT that involves, let's say, vaping, which is actually proven to be the single most effective way to get people to reduce or to completely eliminate smoking. It is not FDA approved, but then again, neither is cannabis. And we understand that sometimes FDA approval is not necessarily in conjunction with best practices. We'd like to then add that in addition to nicotine, NRT, and vaping, that you add along with the pharmacy's recommendation that they talk about support groups. They talk about licensed clinical physicians, smoking cessation counselors, and others that are part of the greater body, and that all this information gets packaged into a comprehensive bundle that is then presented to every patient and made widely available to the entire public. Thank you.
Thank you. Right on time. Thank you, Mr. Weber. Kaylee Locklear.
Good afternoon again, honorable members of the committee. Again, Kaylee Locklear here on behalf of the Maryland Association of Chain Drugstores in support of this legislation, but with an amendment. We did reach out to the sponsor's office. Thank you for communicating with us about it. So again, we're here in support. We'd ask for an amendment, though, to address the issue of payment parity for our providers. Pharmacists and pharmacies continue to make significant differences in patient outcomes and have proven over and over again that they partner well with patients, communities, and other healthcare providers. But unfortunately, without a reimbursement mechanism, most providers will likely put a cost on this service if they offer it at all. The pharmacy prescription reimbursement model is already under pressure with DIR fees, low margins, and increasing labor costs, and to not be reimbursed for services that other healthcare professionals already perform and are reimbursed for, it just doesn't make sense. I also want to add that the Maryland Pharmacists Association supports the bill with this amendment as well. And to quote Aaliyah Horton, who is their executive director, I know many of you know her, this is not coverage for a new service. This is pay equity. If others get paid, we should too. So we are here in support of the ability to prescribe these important cessation products, but would respectfully ask you all for an amendment for payment parity. Thank you.
Thank you, Ms. Locklear. And I'm just going to ask one more time whether Mr. Akwakoku has returned to the room. He has signed up as favorable with amendment. Seeing that he is not here, I'll just encourage you to look at all of the testimony in our folder. And there's a question from Senator Lamb. Senator?
Yeah, thank you, Vice Chair. So a question for this panel. I just want to make clear that this bill as drafted only covers nicotine replacement products, right? So it would not cover things like Zyban and Chantix, which have other implications for use, right? Can someone on the panel clarify that?
Hi, yes, as the bill is written, this only, this would not include bupropion or varenicline.
Right. Okay. And that I think, as a reminder, was how the bill that left this committee back in 2020 was postured. I think too that there was, a broad discussion that took place, and the bill that passed out of this committee, and then I think actually passed out of the Senate floor 47-0, is the same posture that we're seeing now. It does not include Chantix, Zyban, and such. There is one question, I guess, that came up from the written testimony that the Board of Physicians submitted, which is they question whether or not the definition of tobacco replacement products is distinct from that it only draws in these nicotine replacement products that we were talking about, like the patch and the gum, and does not include tobacco cessation products like Zyban and Chantix. Any need to clarify that, or any interest in clarifying that based on what the Board of Pharmacy has submitted in written testimony? Or do you think this is sufficient as drafted?
I had the opportunity to speak with the Board of Pharmacy prior, approximately a couple weeks ago, to clarify that point, and pointed out that the wording in the bill was such that it specified nicotine replacement therapy, not the tobacco cessation products. And they did not find that further clarification was needed at that time.
Thank you, Dr.
Okay.
Thank you, Senator Lamb. Kristen Watson, you're in the room. Why don't you give us your views, and then we will see if there are any other questions and wrap up this bill.
Yeah, thank you so much. I am here to support the bill. My name is Kristen Watson. I'm an associate professor at the University of Maryland School of Pharmacy, and I have had the privilege for the past 15 years of serving as an ambulatory care pharmacist within the VA, providing care for our veterans who have cardiac diseases. So in my role, I have had the privilege to sit and form relationships with my patients and working through them with smoking cessation. As Dr. Martin said earlier, smoking cessation is so incredibly hard for our patients. Most of them need multiple attempts. So it's forming these relationships and allowing, why we're here and asking for support of this bill, is really to allow access to those that we care for in Maryland, to have multiple clinicians that can be involved with their care, and to provide that access for the nicotine replacement products. While I know the nicotine replacement products are available over the counter, data from the Surgeon General report that came out in 2020 reported that only a little over 57% of patients who wanted to quit received either a prescription or specific recommendations on quitting. With nicotine replacement products, absolutely could a patient walk into the pharmacy, pick up their NRT, and read on the box what the dose may be. However, based on our experiences, pharmacists, physicians, nurse practitioners, we know that it's not always one size fits all with that. So we have to come together and develop a plan, including, is it the patch, plus maybe the lozenges or the gum. Also, providing that one-on-one counseling with our patients can really help us determine with them what's the best time to place that patch on to the body, what are the potential side effects, and how can we minimize those when we occur. The last thing as any of us as clinicians want to see is a patient developing side effects from therapy and not being able to take it. And I just am here to, as a pharmacist who is so deeply committed to the care of the people that we serve, especially those in Maryland, that we are really here to try to help expand access for our Marylanders, and helping prevent this fight against smoking use and giving them the best direction and the best chance that they have for quitting. So thank you for allowing me the time to speak to you today.
Thank you very much. I appreciate your advocacy and your expertise, Ms. Watson. Colleagues, just for the record, other people who submitted written testimony include the University of Maryland School of Pharmacy, the Lung Association, Advanced Practice Clinicians, Society of Addiction Medicine, against it, unfavorable, or MedChi, and the Board of Pharmacy. So Senator Hester, I see that you have a question, and then we will finish up on this bill.
Thank you, Madam Chair. Just really quickly,
Will anything in this bill change something that it can currently be bought over the counter to requiring a prescription?
I see Watson shaking her head. Do you want to verbalize it for anyone with disabilities who can't see that?
Sure, absolutely. This will not change the status of any of the medications. People will still be able to purchase things over the counter if they want. It will just be able to provide the ability for people to have this covered by their insurance.
Thank you, Senator Hester, for the question. Seeing no other question, that completes the hearing on Senate Bill 62.
Thank you.
Still have a long way to go, colleagues. Next up is Senator West, Senate Bill 77, but I did not see him in the room yet.
Yep, checking on him now, Senator Kagan.
But I see that Senator Jackson has been here, so I'd like to skip to him on Senate Bill 230. Good with that, Senator Jackson. Are your witnesses in the room?
Let me check. I think some of his witnesses are here.
All right, so
I'm ready. I'm ready if you are.
All right, so Senator Jackson, we're going to go, colleagues, to Senate Bill 230, Health Occupation Service Members, Veterans and Military Spouses, Temporary Licensure, Certification, Registration, and Permitting. Welcome to EHE, Senator.
Thank you very much, Madam Vice Chair Kagan and committee members. For the record, Senator Michael Jackson, representing District 27, and in my capacity as chair of the Senate Veterans Caucus on behalf of Senate Bill 230. Senate Bill 230 would create a process requiring each health occupations board to allow for experienced healthcare professionals who also happen to be service members, military spouses, and veterans to receive temporary licensure in multiple health occupations, provided these individuals meet a few criteria. The individual must provide proof that they are a service member, a veteran, or a military spouse, having been assigned to a duty station in Maryland and has an established legal residence here. The individual must provide proof that they have held a valid license or similar certification in another state for at least 1 year and be in good standing in said other state. And finally,
Michael Jackson is presenting a bill.
Yeah. Senator West, you're not muted. We go ahead and, sorry, Senator Jackson, go ahead.
No problem. And finally, the individual must provide proof that they have applied for full licensure, certification, registration, or permit in Maryland and pay all required fees and to require criminal history record checks. This legislation will be applicable in numerous fields and help fill needs in a variety of healthcare professions, including but not limited to acupuncture, audiology, dentistry, nursing, and social work. The aim of this legislation is to create a mutually beneficial situation for both the state and military members and their families whose service brings them to Maryland. Often military members and their family members are forced to work at levels below their expertise because of a lack of certification relating to licensing issues brought about by the moves that the military service requires. Among other things, they can create unnecessary financial hardships while individuals wait for the licensure and or certification to be processed. With the need for healthcare professionals at a premium, it's imperative that we get qualified individuals to work as quickly as possible. I believe this legislation does that and helps our military community at the same time. So, Madam Vice Chair, I would ask you and the committee for a favorable report, and I hope our panel is available.
Yes, we have it here for you. Thank you, Senator Jackson. Witness Christopher Arnold from the Department of Defense, Military Community and Family Policy Office. Is Mr. Arnold here? I think I saw.
I am, Madam Vice Chair.
Welcome.
Thank you so much. Great to be back here again. I'll be seeing you a lot over the next several days. The Department of Defense is grateful for the opportunity to support the policies reflected in Senate Bill 230. I am Christopher Arnold, Northeast Region Liaison at the United States Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. I am also an Army combat vet, but shout out to Senator Ellis and the Air Force. I will endeavor not to repeat much of what my written testimony has already said about DoD's ongoing evaluation of license portability in Maryland and federal statute, which includes licensure as a part of the military services strategic basing criteria. Taking care of our families is the fourth line of effort in our national defense strategy, and the First Lady, Dr. Biden, has called military spouse licensure a national security imperative. Pre-pandemic research showed unemployment rates for licensed military spouses ranged as high as 28%. From 2011 through 2016, the department asked states to improve license reciprocity for service members and military spouses, securing passage of laws, including the Veterans Full Employment Act of 2013 in Maryland. Subsequent and ongoing research proved real-world implementation and outcomes were insufficient to meet the needs of military spouses. Thus, Maryland worked to enhance its licensing practices for military spouses in the labor occupations circa 2020, using a substantially similar approach to Senate Bill 230. But the health occupations remain an area ripe for policy improvement to fulfill DoD's bottom line to allow a military spouse to receive a license with minimal initial paperwork within 30 days of an application. The department perceives interstate compacts as the optimum long-term solution to portability, an area where Maryland and this committee has unquestionably become a leader nationwide. As there is not currently a compact for every occupation, nor is every state a member of each compact, the department continues to engage the states on the issue of military spouse licensure and pursue a variety of approaches to reciprocity simultaneously. The best evidence we have about the quality benefits of licensure relate to occupations that are universally licensed, which tend to have more harmonized standards across states. Where we do not have any strong evidence is to suggest that the type of license recognition in Senate Bill 230 is associated with worse quality or worse care outcomes. Current health occupation licensure policy remains a significant barrier to military partnership with community healthcare facilities and for military healthcare professionals to meet wartime readiness requirements. While the bill likely affects a relatively small number of applicants, no number is too small, and many members of this committee have helped the department resolve over a dozen licensing issues affecting military spouses in just the past 12 months. JBA has reported onboarding delays of 3 to 12 months for the world's best trauma surgeons and military spouse physicians, which results in limited medical personnel readiness value. The spouse of the Chief Master Sergeant of the Space Force, coming from a non-compact state, required 6 months to have her license approved. Regardless of the military spouse's years of experience in an occupation, boards often look to test scores and academic records to assess competency. Those military spouses who have maintained a successful career in an occupation in a variety of locations and circumstances express frustration over having to justify their credibility and competency in the same manner as first-time applicants. Providing a temporary license allows the military spouse to practice while fulfilling requirements needed to qualify for endorsement in Maryland or awaiting verification of documentation supporting the endorsement. The enhancement provided by Senate Bill 230 ensures temporary license should require minimum documentation, such as proof of holding a current license in good standing, and marriage to an active duty service member who is assigned to Maryland. This type of well-designed licensure regime can enhance public safety while expanding healthcare access in historically underserved communities and participation in the workforce by historically excluded groups, such as military spouses. We are particularly grateful to Chairman Pinsky, Vice Chair Kagan, and of course the bill sponsor, Senator Jackson, and all the members of the Veterans Caucus for all of your efforts and work on this legislation over the past year. On behalf of the Department of Defense, we thank you for considering the policy expressed in the legislation. And as always, as liaison to the Northeast, I stand ready to answer whatever questions you may have.
Thank you so much. We appreciate your service, your leadership, and your presence today, Mr. Arnold. We look forward to seeing you whenever you've got something to share. We also have Owen Karen, if he is in the room, with 316 MDG. Mr. Karen, I wasn't sure whether he was in the room yet, but he also submitted written testimony. Scott Tiffin, licensed clinical professional counselors of Maryland and the Maryland Nurses Association. Mr. Tiffin, there you go.
Yep.
Welcome.
Hey, thank you, Madam Chair and members of the committee. My name is Scott Tiffin, and I'm here on behalf of the OT Association, as well as the Licensed Professional Counselor Association. We're favorable with amendment to this bill. I think we definitely agree with the idea of making sure that our veterans, our military members, and their spouses are able to get, effective, fast licensure here in Maryland. To the boards we've talked to, and to some of our members we have talked to, we're not aware of there being an issue of people not being able to get expedited licensure. But if there is a problem, we definitely would like to be a part of a conversation to help speed that process up for these folks. We also in particular wanted to flag some concern about what we see in the bill is a possible way to licensure while you're completing the requirements for a full license, and just wanted to make sure that we weren't letting folks be licensed in Maryland who may otherwise not be qualified, and possibly causing patient safety risk. But our main point is that we want to support this effort and want to be participants in any conversation to help people get licensed here in Maryland as quickly as possible.
Mr. Tiven, thank you for your brevity. I do clarify, you signed up as favorable, but you just said you were favorable with amendment.
That was probably my fault. I probably clicked the wrong button. I apologize.
Okay, but your written testimony, I assume, has your suggested amendment.
Yep.
Moving on, Robin Elliott is with us, Maryland Nurses Association. I saw Robin a little bit earlier. Here you are. Welcome to you.
Thank you, Madam Chair and members of the committee. Robin Elliott, I'm here today on behalf of the Maryland Nurses Association. Also favorable with the amendment. I hope I click the right button on that. Very much want to thank the senator for introducing this legislation. It has always been a priority of the Maryland Nurses Association to support military members, veterans, and spouses. We were big supporters. About 9 years ago, you all passed a bill to make sure that expedited licensure applied to all health occupations and business occupations. And we think for the most part that works pretty well. We recognize that there's some isolated incidents. And of course, we have the ransomware issue at MDH right now. Overall, I just want to say that probably any nurse or any other practitioner who is in the military or a veteran member would meet Maryland licensure requirements. That's certainly true for nurses. Our main concern, I think, is one that Mr. Tiffin mentioned, is that there is a provision in this bill that would allow individuals to practice as nurses, even if they don't meet some core Maryland requirements. And so certainly we think they could practice under kind of another title or in some other capacity, but not as nurses. So we'd like to look at that. And then we wanted to flag just a quick issue. One of the problems with temporary licensure, which is provided by this bill, is if you have a temporary license, you probably cannot bill insurance or Medicaid. That could be kind of an unintended consequence of emphasizing temporary licensure. We do think there are occasions where temporary licensure is warranted. Nurses have a temporary licensure status under certain circumstances, and we really appreciate Senator Jackson bringing this bill forward, because there may very well be some other circumstances. For instance, you just didn't get the important piece of paper back from another agency and you're waiting on that. There may be some circumstances where we really should look at temporary licensure. So thank you to Senator Jackson for bringing that up, and we pledge to work with the committee.
Thank you very much, Ms. Elliott. Lynn Nash, Maryland Military Coalition Commissioned Officers Association of the U.S. Public Health Service. Ms. Nash.
Thank you very much. Good afternoon, Madam Vice Chair and members of the committee. My name is Captain Lynn Nash, and I'm a nurse, and I have been the Communications Director for the Maryland Military Coalition for the last couple of years. I served 30 years in both the Army and the Public Health Service, and I retired in 2017. Most recently, I've been a medical vaccinator with Maryland Responds and the Medical Reserve Corps, where I've personally given over 15,000 COVID vaccines in and around Gaithersburg, where I live. As a Vermont licensed nurse, I'm only able to vaccinate now because Governor Hogan used his emergency powers as part of the emergency declaration to allow practitioners from other states to join and help without a Maryland license. Vermont, the state where I'm licensed, won't join the 37 states currently in the nursing compact until later this year. Currently, Maryland regulates 20 health occupations, and the one board that seems to be having the most problems in timeliness and responding to licensure applications is the nursing board. this bill would allow for temporary or expedited license certification and registration to service members. When I was a federal nurse, my Vermont license was recognized. I didn't have to get relicensed every time I was reassigned unless I wanted to moonlight. Today, to practice or serve as nursing faculty in Maryland, where there is a critical shortage, and I have a PhD, I would have to go through the onerous and frankly expensive process of getting licensed in Maryland. It's about $400 by the time that you get it all done. And this cost would be in addition to maintaining my Vermont license. This is a good bill, but I think you're missing a huge group. I represent 1,200 public health officers in Maryland, and they're not included in this. You're talking only about the armed forces, not the uniformed services. So I would ask that you include both NOAA and the Public Health Service, because we have huge numbers living and working here in the state. And secondly, I'd like you to remove the restriction on a veteran who has retired within just 1 year. As you know, the first year of retirement is usually honeymoon and the honeydew list. Most people don't make the decision to get a follow-on job until we've had a little bit of time to attack those.
Thank you, Captain Nash.
Thank you.
Thank you for your service. Thank you for being with us, and thank you for your suggested amendment. I'm going to give one more shout out to see if Owen Karen has joined us. I don't see him in the room, so I can mention that he has submitted written testimony. Before I call on the chairman, I just want to flag that there is unfavorable testimony from the Board of Physicians, from 2 different people there, with the health occupation boards, from 2 different people there, the Department of Health, Office of Governmental Affairs, and the Office of, 2 different people have signed up against. So with that, Mr. Chairman.
Thank you, Madam Vice Chair. I clearly see the need for this legislation, but I did a little work, and I see that in 2013, we passed the Veterans Full Employment Act, chapters 154 and 155, that put into law an expedited license and support from the board to have an advisor to assist military people. It's my understanding we have a temporary license for military people. We credit experience of training or education as a service member and some other elements. So I guess my question is to Mr. Arnold or someone else, does the current law not suffice? Is it a shortcoming? And how is this different from all other pieces of legislation that we've passed?
Certainly, Chairman. Happy to provide additional granularity in that respect. So from 2011 to 2016, the department did engage the states with the request to make one of 3 potential approaches to providing not only licensure for service members, but particularly their spouses, which for your edification has now, pursuant to Section 2883 of the fiscal year 2020 National Defense Authorization Act, become a factor that the military service secretaries must consider whenever making a basing decision. And indeed, they publish annual scorecards at the installation level to evaluate license reciprocity within the state. And the first Air Force scorecard, released in 2019, adjudged Maryland as one of only 2 states that was red in the whole country.
Yeah, but Mr. Arnold, am I wrong in that we passed legislation setting up?
So that got us to President Ferguson and Speaker Jones under the auspices of what we refer to as licensure enhancement along our continuum for license reciprocity. Because those original 3 lines of effort to provide expedited licensure or temporary licensure or licensure by endorsement, the research demonstrated that states had differing definitions for what constituted expedited or reciprocal. So now our bottom line is a license issued within 30 days with a minimum of paperwork, such as on submission of an affidavit. And we perceived that that bill would get us here. So we've done a tremendous amount of study. In October 2020, we contracted with the Clearinghouse for Military Family Readiness at Pennsylvania State University to conduct a review of licensing of military spouses in 6 professions across all 50 states, which addressed licensing in the same manner as the previous study accomplished by the Center for Military Reach at the University of Minnesota and Auburn University in 2017. And the findings—
Mr. Arnold,
Yes,
let's
sir.
make this real simple. The language we have in the law that we adopted in 2013, it's 2.5-103 in the building regulations. Have you reviewed that, and have you found that wanting?
Copy. We found it insufficient to meet the underlying needs of military spouses. And indeed, the SecDef sent a letter to Governor Hogan recommending legislation that provides support for temporary licenses for military spouses licensed in another state, as most boards do not offer that option.
Okay, thank you.
Thank you, Mr. Chairman. And Mr. Arnold, SecDef, I assume, is the Secretary of Defense. So just want to acknowledge colleagues that there are a bunch of other people who submitted favorable in writing, and the Maryland Department of Health also submitted favorable with amendment in addition to submitting in opposition. So we've got a range of positions from them. Ms. Hanson-Mundell, the questions unfortunately are from senators right now. I see that you have raised your hand. So unfortunately, I'm not going to be able to call on you, and I didn't see you signed up as a witness. Senator Carrozza, followed by Senator Lamb.
Thank you, Madam Vice Chair. Senator Jackson, thank you for this legislation. We've discussed this issue in our Veterans Caucus meetings. My question is for Mr. Arnold. And Mr. Arnold, welcome. I held a similar position in the past doing congressional relations, so I realize it's the challenges you have at this point. In your testimony that you submitted on page 5, you underscore that professional licensure has been an enduring problem for military spouses. And then on the next page, you outline, and we like visuals here, the immediate actions, near-term actions, and long-term solutions on how to address this issue. And my question for you is, how do you think overall, especially given that we have a health professional shortage, not only in Maryland, but elsewhere, how do you think Maryland is doing when you look at those immediate actions, near-term actions, and long-term solutions, given that some of us have been working on these compact bills as well to try to, address the issue, not only for military spouses, but it also helps with our, overall with our workforce shortage in the healthcare arena.
Thank you for the question, Senator. And pursuant to congressional requirement, the department has entered into a cooperative agreement with what is known as the National Center for Interstate Compacts, which is part of the Council of State Governments. And we provide ongoing funding, for the development of new licensing compacts. We announced the first round in 2021 and expect to announce 5 more next month, so stay tuned. And certainly on that continuum, you can see that compacts are reflected as the darkest shade of green. Because if our baseline is a license within 30 days, there's really nothing for the spouse to do if they're going from a compact state to a compact state. And as this committee has rightly recognized, Maryland residents who are serving in other compact states also benefit from that same type of instant reciprocity. And while the research is out in the field, I believe that preliminary results indicate that underutilized medical talent traveling to high needs areas can have their experience streamlined when transversing between 2 compact states. But as you referenced, the department is working on 3 lines of effort: immediate actions to fully implement those laws that were passed between 2011 and 2016, which for Maryland on the continuum would be the amber, and make those practices and policies accessible to military spouses. So I encourage members of the committee to go on the board's websites and see for yourself. Is there a button for a military spouse applicant to click? Does the application have a box to check asking if the person has served in the military services or is the spouse of someone who is serving? And then for that near-term effort, intra-state portability, if you will, as there is not a compact for every occupation, nor is every state a member of each compact, enhancing those existing policies to provide additional pathways, whether that's temporary licenses, which in my 11-state region, we were able to effectuate in Maine and Connecticut last year, or whether that's some new pathway to licensure by endorsement as Massachusetts is currently pursuing this year.
Thank you.
Okay, thank you, Senator Croza. Next, Senator Lamb.
All right, thank you. As a preventive medicine and public health physician, I am sympathetic to Captain Nash's concern about not including uniformed services. So I guess this question is to the sponsor. Besides the 6 armed forces, which include Coast Guard and now Space Command, any objections to including the rest of the uniformed services in this bill by amendment?
No, as a former uniform member myself, I have no issues with that, Senator.
Okay, great. Thank you.
Senator
That's it.
Senator Ellis.
Thank you, Madam Vice Chair. So I'd just like to follow up on Chairman Pinsky's question. In my 4 years here in Annapolis, serving on EHE 4th session, I kind of remember at least 2 bills that came through which address this issue. Now we have so many bills, even though a lot of times it might pass EHE, the committee that we are here serving on, it might not pass the entire General Assembly. And so it seems like we've continually addressing this issue at least every year. I mean, so, Mr. Arnold mentioned compact. So I know compact is another topic, and several other folks have mentioned compact. Is this bill to elevate it, what we've done in previous years, recent years, to a compact? And of course, Mr. Arnold and Captain Nash, thank you for your service and thank you for being here.
Copy, Senator. So no, this would supplement the state's efforts to accede to compacts, which in terms of the scorecard for portability, if you will, are assessed as a state's future commitments to license reciprocity. This would satisfy our near-term effort to enhance existing intra-state policies that support the bottom line to issue a license to a military spouse within 30 days of their occupation. And I will note that we work on sort of a 2-year cycle in my office. So this issue first came onto our plate in 2019, and the state moved almost immediately to respond to the ask. And, you know, it was done for the labor occupations and sponsored by the Speaker and the Senate President, which I think speaks to the importance of the issue. So I would personally love to move Maryland to green, but they gave you amber because the health occupations were omitted. And we're certainly sensitive to the concerns about uniform services. For those of you who have seen my presentation, the next, one of our top 10 key issues on the David Letterman list that are determined by the Office of the Secretary of Defense and the Service Secretaries is known as Uniform Services Support Equity, which would seek to encompass the Space Force, the National Oceanographic and Aviation Administration, uniformed officers in the United States Public Health Service into the context of issues that we've previously asked you for. So we asked you to do this, now we're asking you to update it. So the 2013 law was appropriate in the context at the time, and I think the research that we submitted along with user experience has indicated that there is room to do better.
Senator Ellis, you good?
I am good. Thank you, Madam Vice Chair.
Thank you for the question, and as always, we appreciate your service to our nation as well. Senator Hester, and then we'll wrap up this hearing.
Thank you, Madam Chair. I'd like to thank the bill sponsor, Senator Jackson, for bringing this bill forward, and Mr. Arnold for your thoughtful answers to questions. Either one of you could answer this one. I'm in full support of this bill. I did have a question. Several of the boards note that the issue of expiration of or renewal of a temporary license is not addressed. And then something about a CHRC, a criminal history records check. Are you in the process of working to address those concerns?
If I may start, Sharon, if the third criteria that I mentioned would require, it would submit to a required criminal history record check. So that's already in the piece of legislation we're proposing.
Good, Senator Hester?
And my office is sort of the carrot, if you will. We can show you the best practice and what other states are doing and the policy aim, which is to obtain, that license within 30 days. So I believe the legislation articulates an approach whereby the applicant would not be issued the temporary license until the results of the background check would be completed.
Thank you very much. Count me in.
Thank you, Senator. Thank you, Senator Jackson. Good to have you in EHE. That completes the hearing on Senate Bill 230. We now go to our friend Senator West. Senator Jackson had been in the room, and so we let him pull holds over when you weren't here yet, but we're glad you're here now. So Senate Bill 77 is Health Occupations Board Investigations Right to Counsel. And we're glad you're here. You may begin your testimony.
Thank you, Madam Vice Chair, and I'm here too. Just a brief apology. The last time the hearing was concluded, my staff had not gotten a call. So by the time I did all what was necessary to get my hearings in my committee and get into this hearing here, Senator Jackson had started. And to add insult to injury, even though my screen showed that I was muted, obviously I was not muted. So clearly this Zoom process still has some bugs. At any rate, it's great to be here to present Senate Bill 77. Sometimes complaints are filed complaining about the conduct of medical professionals. And when that happens, the relevant licensing board begins an investigation to find out what went on. The disciplinary process for a license or certificate holder in healthcare has the potential to end someone's right to practice medicine, disparaging their reputation along the way. Some of the investigators for health occupation boards can have a rather aggressive style of interviewing, especially if they have limited healthcare experience. Restricting the right to counsel during an investigation allows these interviewers to frame biased questions, falsely implying allegations, and making the license holder inadvertently give erroneous responses. While there is no constitutional right to counsel during interviews, there is nonetheless a property right to a professional license, and therefore it's appropriate for the license holder to have counsel to protect this interest. Senate Bill 77 merely provides that a license or certificate holding healthcare worker under investigation by a healthcare board that may result in charges or sanctions or even the forfeiture of the medical license is entitled to counsel during the investigation and interviews. The right to an attorney is an integral part of the American justice system, and it should be available to medical professionals in danger of being sanctioned or losing their license to practice medicine. Now, after the bill was introduced, a number of letters were filed suggesting that we proposed an amendment to the bill delineating the proper and acceptable role of a lawyer in these circumstances, because the role could range anywhere from being a potted plant on the one side to disrupting the proceedings on the other side. The obvious answer is the role of a lawyer should be to act as a professional lawyer. So we've introduced an amendment, which I hope you have. If you don't, I will get it to you, which delineates what the role of counsel should be under these circumstances. And there are four things a counsel should be permitted to do. Number one, ask the licensee questions. Number two, ask that a question of the investigator be clarified. Number 3, provide advice to the licensee. And number 4, provide information relevant to the investigation on behalf of the licensee. That's it. So I think that amendment would answer the relevant questions that have been raised by some of the people who filed favorable with amendments, or even some of those that have filed objections. And with that, I turn the bill over to the committee. I will say that the first witness, I think, is going to be Natalie McSherry. Natalie, summer law clerks together in my law firm, Sims, Bone and Sims, in 1973. We have literally known each other for 49 years. Natalie is currently the president of the Maryland State Bar Association, but I believe she's appearing this afternoon in her private capacity as a practicing lawyer rather than on behalf of the MSBA. Thanks.
All right, thank you, Senator West and colleagues. The amendment that Senator West referenced is stapled to his testimony, so it is not a separate piece of paper. Ms. McSherry, 1973 certainly could not have been 49 years ago. That's impossible because it feels like recent past, but welcome to EHE.
Senator Kagan, I'm sorry to interrupt. I'm so sorry. Did you see my chat really quick?
I did. Yeah, I'll message you back.
I just wanted to make sure you did. Okay. I just wanted to get back to them. Thank you.
Thank you so much.
Yep. Thank you, Vice Chair Kagan and Chair Pinsky. And thank you to Senator West for letting me be here today. And I don't really thank him for letting you all know how long we've known each other, because it certainly does date me. But for at least 20 of the years that we've known each other and that I've been practicing law, I have been representing, and let me first add on to Senator West's disclaimer, I am here today as a private practitioner. I am not here today on behalf of or as president of the Maryland State Bar Association. So thank you for reminding me of that, Senator West, and I wanted to reiterate it. But I am a private practitioner. I have represented practitioners before any number of the health licensing boards in this state. And let me say that, first of all, as Senator West said, there are some practices that are unfortunate. They are not uniform by any stretch, but that is why I believe it is advantageous that there be a statutory right, first of all, to have an attorney present at these very important interviews. And secondly, that attorney be allowed to actually participate in the interviews. I will tell you that some, not all, of the licensing boards have investigators who have no background training or experience in the occupation that they are actually investigating. Many of them are former law enforcement who have no training in healthcare at all. But they do have training in criminal prosecutions, and they frequently approach these interviews like a criminal interview. And that is where this issue has arisen, because there is a now very dated memorandum from the Office of the Attorney General correctly pointing out that there is no constitutional right to counsel in these interviews. But clearly, as Senator West said, there's a very important and valuable property right at interest. And it is our suggestion that licensees should be uniformly allowed by statute to have counsel present and participate in these interviews in the way that Senator West has delineated. I want to make sure that you understand that we don't mean, as at least one of the letter writers suggested, to be disruptive to the interviews, but simply to protect our clients' rights in the interviews and to provide the factual, neutral information that the investigation should be intended to generate. So that is the gist of it. I also submitted some written testimony, and I'd be happy to take any questions.
Hold on. Thank you, McSherry. The next is Natasha Wesker. Welcome, Ms. Wesker. Natasha Wesker. Is she in the room? Okay, let's move on. I saw Nicole Hanson-Mundell was in the room. Ms. Hanson-Mundell, are you still in the room? Okay, we're striking out here. Well, let's shift to favorable with amendment. Dan Doherty with the Maryland State Dental Association. Mr. Doherty, I see you.
Thank you, Madam Chair, members of the committee. I'm Dan Doherty. I'm here on behalf of the Maryland State Dental Association. And I couldn't agree more with the sponsor that obviously healthcare providers during investigations by the board, which puts in jeopardy their licensure status, should have the right to counsel. My client's concern, though, is that there would be a loophole in the way the bill's drafted and probably even with the senator's amendments, that if the board, for example, receives a verifiable complaint that there is illegal activity going on in a provider's office, whether it's false or fraudulent prescriptions, drug distribution, totally incompetent practice, which we've had in one scenario in Anne Arundel County in dentistry. The board sends out an investigator unannounced to go to the office and try and obtain evidence that substantiates that complaint. And what we do not want to see is to have that investigator arrive and have the licensee, dentist, physician, whatever, step in and say, halt, you're in an investigation of me. I want my counsel here, and have things delayed. I have brought this issue up with Senator West, and we both feel that we can, as a group, come together with language that will address that. So with that, I would say we support the intent of the bill. We'd like to have some clarification in that one area, and we're more than willing to work with all parties.
Yes. The Maryland Department of Health.
Thank you very much, Mr. Doherty. Also favorable with the amendment, I saw Richard Block.
Thank you, Madam Vice Chair and members of the committee. I appreciate the opportunity. I'm here in 3 different capacities: individually as an attorney who represents predominantly in front of the mental health boards. I'm here as general counsel to the Maryland Psychological Association, and I'm here on behalf of the Maryland Podiatric Medical Association, which I am executive director and general counsel. All of us support this bill with amendments and would consider the amendments that the sponsor has put together, and we appreciate them, Senator West. This bill gives to mental health and other providers the opportunity to protect themselves against the issues which have been very nicely and very adequately stated by Ms. McSherry, who unfortunately I preceded by at least a year and a half, but we won't go there. The reality is that it varies from board to board, the ability of an attorney to represent their client at these interviews. And this bill would allow uniformity across the boards to protect the rights of a licensee, because the presumption, if it goes to investigation, is that there was something done wrong. And that's the approach that most investigators are taking, even though they're supposed to be unbiased. And as a result, licensees can very often be confused, misinterpreted, or the like. And when you read transcripts, you don't always get the emotional response that's important when someone's being interviewed. So the presence of an attorney would help protect the individual licensee in these circumstances. And that's the only purpose. It's not to deprive the public of their protection that the boards provide. As we all know, the boards are generally autonomous. There are very limited bases on which their decisions can be appealed. So the interview is a critical element in the investigative process before the boards make a decision as to whether to proceed or not against the licensee.
Mr. Block, if you could wrap up your testimony.
I'm done. Thank you,
Perfect.
Madam Vice Chair.
I appreciate that. Thank you so much.
I would say I submitted a minor amendment to cover registered psych associates that were inadvertently left out.
That is okay. I am going to ask again to see whether Natasha Wesker is in the room and whether Ms. Hanson Mundell is back in the room. I see neither of them. So we're going to go to unfavorable with Matthew Dudzik, the Maryland Board of Physicians. Mr. Dudzik.
Good afternoon, Matthew Dudzik with the Maryland Board of Physicians. And just to clarify, we have not had a chance to review the senator's proffered amendments. I don't think that anyone here, myself included, opposes the idea of allowing physicians to seek private counsel during the disciplinary process. So I do want to make it clear that the Board of Physicians has always allowed its licensees to be represented by counsel at every stage of the investigative and disciplinary process, including during interviews. There are actually already existing regulations that state that a respondent may be represented by counsel in any matter before a disciplinary panel and during any stage of the disciplinary proceedings. And historically, we have always allowed counsel to participate in these interviews. Our primary concern is to exercise some caution in creating overly broad language to this effect. And as Ms. McSherry pointed out, in a vast majority of cases, this is not an issue. Most counsel is not disruptive. Most counsel, there's no issue at all. In 9 out of 10 cases, if SB 77 passed, it would have no impact on the board because it is something that we already allow. However, while it is rare, we have had instances where counsel becomes actively disruptive in interviews to the point of impeding our investigations. As Ms. McSherry noted, these are not criminal investigations, and these interviews are not depositions or court hearings. There is no officer of the court who can rule on objections or inform counsel that they're out of line. In those rare instances, our only recourse is to inform counsel that if they continue to disrupt the interview, they may be asked to leave. Our primary concern would be that SB 77 may remove that ability, which could create delays in investigations and in some cases prevent us from acting outright. The board is not out to get anyone. The majority of investigations do not result in charges. But our primary duty is to protect Maryland patients, and we can only do this through these lawful investigations. We are committed to making sure that this process is fair for all of those who are involved, and we are happy to work with the committee and work with Senator West to find amendments that will make this bill a little bit narrower in scope, but still accomplish the same goals. We have no issue with the goals of ensuring that all of our licensees have that ability. We've been looking at how some other states have handled the issue. As I said, we haven't had a chance to review the senator's proffered amendments, but we do know that the dental board also submitted a proposed amendment that may alleviate some of our concerns. But we do think that some mechanism to actively address those rare instances of disruptive counsel is necessary. And lacking that, urge an unfavorable report on SB 77. Thank you.
Thank you, Mr. Dudzik. I am guessing that Senator West will want to chat with you and see your thoughts. I want to flag that we have favorable testimony from a whole bunch of folks, including MidCai and the Maryland Association for the Treatment of Opioid Dependence, AFSCME, the American Federation of State, County, and Municipal Employees, Health Facilities Association of Maryland, nurse practitioners, the social workers, MCA, it doesn't say what that is. So in any case, Senator Ellis.
Thank you, Madam Vice Chair, and interesting topic. Senator West, thank you, Bill, and the thought process that I'm going through at least. So I have a couple questions. One question, Senator West, maybe Ms. McSherry can answer this. I'm not sure. Tag team it, I'm not sure. But are there any other professions in Maryland that has this benefit of professional under investigation allowed to have counsel? CPAs or plumbers, I'm not sure, electricians.
I guess it's a good question. I haven't investigated the others.
Senator West, I can tell you that I'm not aware of another statutory right. Senator Ellis, I'm also not aware, because I've represented people in some of the other non-health regulatory boards, and it's never been an issue there. So it just hasn't come up there, but I'm not aware of any other statutory right.
Okay, yeah, thank you for that. And so my second question is, I'm just listening to the back and forth there. So there's an investigation, right? Where an investigator comes in to say a physician's office and speak to employees. look at processes and systems and controls, or, you know, whatever term you want to use. And then there is actually speaking to the practitioner. I would think in speaking to the practitioner, it goes beyond investigation into interrogation. And in favor, I was thinking that you never know what you can say that will be misinterpreted, right? And so, I mean, can we make that distinction in this bill to say, hey, you can investigate, but when it comes to actually question and interrogation of the practitioner, they have the right to seek counsel, because, you know, you never know, someone could be gregarious and very talkative and go on.
Speaking of talkative, why don't we let our witnesses get
okay.
Ellis?
Dr. Ellis, that's a good question. Let me just say that I will look forward to working with both Mr. Dudzik and Mr. Dougherty to solve their problems by amending the bill slightly. Mr. Dougherty really raised that. He distinguished between the investigation on the one hand, which sometimes, especially in the case of dentists, has to be unexpected when the investigator arrives at the door and hopes to see a problem being perpetrated before his eyes. And an interview, on the other hand, which is a much more deliberative situation in a room with a desk between the two when they're talking. So I think in dealing with Mr. Dougherty's concern, we can fix this bill in a way that would alleviate your concern too, that we don't want attorneys to be disrupting investigations. But we think it's very important that the attorneys be present for the interviews for the witness, where the licensed medical professional might be put under the gun and would need legal counsel to try to assist in the conduct of the interview.
Okay, so your bill doesn't address that, but you said we can amend it to.
Yeah, I think we can amend it easily in such a way as to make sure that legal counsel would not in any way disrupt an investigation, such as the one discussed by Mr. Dougherty, where there's malpractice occurring in a dental office, and the investigator, without any forewarning, arrives at the door and says, "I'm here, I want to see what's going on." It would be inappropriate for the dentist to say, "I'm not going to let you see what's going on until I call a lawyer." I agree with that. And I think we can deal with that in an amendment to the bill.
Great. Thank you, Senator West. Thank you, Madam Vice Chair.
Thank you, Senator Ellis. And Senator West, when you were listing those you wanted to talk to that had amendment suggestion, Richard Block sounded like he had some ideas too. So I just want to.
Yeah, Richard did. By the way, I knew Richard almost as long as I've known Natalie.
That's what it sounded like. We've all been around a while now.
So I'll talk to Richard and we'll take care of his problem as well.
Perfect. All right. That completes the hearing for Senate Bill 77. But I think there is no such thing too much time with Senator Jackson. And so we're just going to take a quick revisit to Senate Bill 230, because Mr. Dudzik, who just testified against Senator West's bill, also was supposed to be testifying on Senator Jackson's bill in opposition. And I completely apologize. Mr. Dudzik, please begin your testimony. And we are going back, you guys, to the service members bill. I apologize. Senator West, you may stay or go. Thank you.
Yeah, and thank you so much for coming back to me. I know it's a complicated process. I want to begin by saying, with regard to Senate Bill 230, while the Board of Physicians is recommending an unfavorable position on the bill, we specifically have issues with the temporary licensure components. The Board of Physicians is strongly committed to reducing and eliminating barriers to licensure. We know exactly how essential it is to Maryland's healthcare workforce to ensure that qualified individuals can begin practicing as quickly as possible, which is doubly true for our service members and their spouses. Our main concern with temporary licenses is that every time we have explored this idea, we came to the conclusion that doing so would not materially decrease the amount of time it takes to become licensed. We pride ourselves on issuing licenses as quickly as possible. The vast majority of licenses are issued within 10 days of the receipt of the fully completed application. and that is for all licensees. We, on top of that, actually have an expedited process for service members and spouses already in place. We have also been working to create multiple alternative pathways to licensure. So we've been working on developing reciprocity agreements with the medical boards in Virginia and the District of Columbia. We are active members of the Interstate Medical Licensure Compact, and we've been working on developing regulations to set up a licensure by endorsement process that would remove many of the credentialing steps for qualified applicants. And then specific to our service members and their spouses, last October, the board also approved some military-specific regulations that I believe Dr. Olczyk was going to address in his testimony. I think he had to go, but we have provided that as well, and I believe it was referenced in our written testimony. The board strongly supports the intent behind Senate Bill 230. We believe that we are already meeting many of the requirements set out within it. We simply believe that the temporary licensure components of the bill are the incorrect approach in this case. Thank you.
Thank you, Mr. Dudzik. And again, apologies to you and to colleagues, but that really, really does complete the bill hearing on Senate Bill 230. Now, Senator Eckert, I was told that you wanted to go last, but you are in the room, and I am happy to take you up next if you're ready, or we can.
I would love to go next, if that's all right with you, Madam Co-Chair, Mr. Chairman.
If I can just officially announce, this is Senate Bill 82. Senator Eckert, Certified Nursing Assistants Licensing Requirements. I'm so sorry. Welcome, Senator Eckert.
Thank you very much. And again, good afternoon, Madam Co-Chair, Mr. Chair, and members of the EHE Committee. Thank you, Senator Addie Eckert, here on behalf of Senate Bill 82. I want to give you a little background on this and how I've gotten involved. I've been working with the Board of Nursing on a number of issues relative to expediting licensure certification, getting into practice, and ensuring safe practice. And one of the issues that has come up is that there had been a little bit of confusion between the various categories of nursing assistants. Currently in Maryland, we have two different categories, a CNA and a GNA. CNA is Certified Nursing Assistant, and a GNA is a Geriatric Nursing Assistant. And then the Board of Nursing also has some other categories associated with that. For the CNA, the practice and the experience, the clinical and the didactic all pertain to acute care systems. The Geriatric Nursing Assistant is all of that and includes then additional few hours and testing, because that's what is expected for safe practice in the long-term care setting and for to meet the standards at CMS for Medicare. Because of that two different levels, the Board of Nursing over the years has worked with their board to be able to streamline those two categories of nursing and bring them into one, to be in alignment with all of the rest of our surrounding states and all the states, as a matter of fact. And so that is why this bill is before you, to be able to make that happen. Now, in order to make that happen, you're going to hear from some folks who are feeling a little bit like, oh my gosh, we can't do that right now. We're in the middle of the pandemic. We can't get employees to begin with. We want to retain those that we already have. And if you give us this to implement in the next year, we're either not going to be able to do it or we're not going to be able to focus on our workforce. Be that as it may, the Board of Nursing recognizes that and has come in with an amendment that you already have that would extend that timeline, at least for 2 years, and then work with the businesses to be able to develop what's called a transition time for figuring out how we can expedite getting those two categories merged together so that we're speaking from one designation to CNA, and then we don't have to trip over the alphabet soup. And you've talked about that a lot today, and I agree with you. Even in discussions with various organizations on this bill, there seemed to be some confusion about entry and what the competencies are and what the hours are. So I'm bringing that before you on behalf of the Board of Nursing, because I think it's really important that you already heard today. We want to make sure that entry into practice is safe. These folks work at the discretion or at the delegation of LPNs and RNs and advanced practice folks now. So it's important that the house be in order, that we build a strong foundation so that we can build upon that as we begin to talk more and more about compacts and working across state lines, and also about upward mobility and lateral mobility in a variety of various settings. So I am here to support this initiative. Hope you give it your favorable consideration and passage. And we look forward to working with members of the industry to be able to resolve the concerns that are out there. And I believe Karen Evans is here, as well as Rhonda from the Board of Nursing, to answer any questions and give their perspective on this. Thank you very much.
Thank you, Senator Eckert. Karen Evans, I saw you earlier. Hopefully you're still here since you are the lead witness.
Hi, yes, I am.
Hey, welcome.
Thank you so much, Madam Vice Chair. I appreciate this opportunity to support this bill for Senator Eckert. One of the concerns that Senator Eckert has already mentioned is that we want to get in line with the rest of the country. One of the concerns I've heard voiced is that there's a lot of differences between the two, where there are not. They have the same curriculum. So the only thing that they would need at this time is testing. So that would be the only difference of doing one or the other. Right now, CNAs are not able to work in long-term care. However, GNAs are able to work in acute and long-term care. So one of the purposes of why we want to go with this is that we saw a need during the pandemic that long-term care was losing a lot of its CNAs. And this way, this will open up the opportunity for them to have others go between the two, and hopefully that would increase the workforce on both. So that was a major concern. I have already put together CNA stakeholders meeting at the last board meeting of last week so that we can review curriculum and also start on a transition process that will really be minimal for the CNAs to transfer over to GNAs. So I think we have a good model to use. And we're looking at, and we've looked at some of the other states in order to make this happen. And yes, I did. And thank you, Senator Eckert, for extending that to 2 years. So thank you so much that the Board of Nursing is in support of this bill, and I thank you for your time and consideration.
Thank you very much, Ms. Evans. There is other favorable testimony in our folders, but it is all written. And so we are going to shift to 2 unfavorable witnesses, Dana Kaufman, Lifespan, and ADSMNCHA Hospice. And she is going to translate all that alphabet soup for us. Ms. Kaufman, welcome.
Thank you very much, Vice Chair Kagan, members of the committee. And to fix the alphabet soup. So I am here on behalf of 4 organizations: Lifespan, the Hospice and Palliative Care Network of Maryland, the Maryland Association of Adult Day Services, and the Maryland National Capital Home Care. And we do have strong concerns about this bill, really for 2 reasons. And just to clarify one point, because it does get confusing, but the CNA, the Certified Nursing Assistant designation, that is the baseline, I guess you could say that the baseline level. And then it is the federal requirements that in order to work in a nursing facility, you have to become a geriatric nursing assistant. So basically a geriatric and nursing assistant has both the CNAs and then this additional classification. And again, that's a federal requirement. Our concern is we have individuals, like I said, in home care, in hospice, in many other areas that do not have to have that GNA requirement, which does have additional exams and things along those lines. Right now, during this pandemic, it has been extremely difficult for us even to maintain our CNAs. And frankly, the workforce crisis was exacerbated by COVID, but it's always been an issue. You can go back, a decade or two, and it's been an issue. So we do have a strong concern about increasing requirements, at this time. I understand that there is an amendment. We haven't seen it yet, but I also want to consider the fact that, the GNA is a geriatric nursing assistant. That's why you have to have that designation to work in a nursing facility. But we have CNAs who work with pediatric patients. So I think it's also questionable of why should they have to have that further education and exam if they're not working with the geriatric population. I think the other issue that we have had isn't really the fact of going from long-term care and acute and trying to maintain our workforce. But, the bottom line, and this is an issue for budget and taxation, I realize, but all of the providers that I represent take Medicaid, and Medicaid does not pay very well. So it was very hard for us during this pandemic to even compete to keep our CNAs with the big box stores and the Amazon warehouse. So
thank you, Ms. Kaufman.
Thank you.
Sorry, we're really trying to stick to the clock here.
Yeah.
First day it's out publicly, so.
No, that's all. It's just hard. We can't see the clock. That's our problem.
Oh, okay.
Yeah.
Yeah, sorry.
So,
Okay, Karen Greenfield
you.
is here from Leading Age Maryland. Mr. Greenfield, welcome.
Yes, thank you, Mr. Chairman, Madam Vice Chair, and members of the committee. Aaron Greenfield here on behalf of Leading Age Maryland, a community of not-for-profit aging services organizations serving residents and clients through a number of facilities and services. You have our written testimony, and we are here in opposition to Senate Bill 82. We have not seen the amendment despite reaching out to the sponsor's office, and I look forward to seeing that amendment. We certainly appreciate the sponsor's intent. However, as CNAs are currently employed in a variety of care settings, and given the current workforce challenges that Ms. Kaufman cited, requiring these individuals to attain a higher level of training and pass an examination during COVID-19, or even 2 years from now when we don't know exactly what the world would look like, would further burden an already burdened workforce. The industry is facing significant workforce challenges. In fact, the Senate has legislation before it to address these issues. Now is not the time to add requirements, and I'm not sure 2 years from now is either. We just don't know. As Ms. Kaufman mentioned, not all CNAs want to work with older adults. Many want to work with pediatrics and in other disciplines. The advanced certification could serve as a disincentive to those interested in the industry. Providers are already stretched with trying to pay high hourly wages without the ability to pass on the cost. Adding this certification would mean paying higher wages without a gradual ramp up to the new pay levels and without any demonstrated proof in the quality of care. Adding requirements at a time when facing a worker crisis would not be helpful. And for those reasons, we respectfully request an unfavorable report on Senate Bill 82.
Thank you, Mr. Greenfield. Colleagues, Marie Tarleton submitted, just wanted to be on the record, favorable. She did not submit written or oral from the Maryland Academy of Advanced Practice Clinicians. 1199 SEIU, the Service Employees International Union, were favorable. Board of Nursing, the Maryland Nurses Association came in with an amendment, and then more unfavorable written from Health Facilities Association and the Hospital Association. I see no questions, so that completes the hearing on Senate Bill 82. Thank you very much, Senator Eckert. Our last bill of the day, yay, Senate Bill 306. Senator Lamb is going to have to hang up the phone if he's going to tell us about this bill. Thank you. Dental hygienists, consultation requirements, healthcare practitioners. Senator Lamb, you should be warned that my mother was a career dental hygienist, for whatever that's worth. We all have to floss regularly. Begin your testimony. You're the bookends. We were first and last today.
All right, sounds good. Well, if she was a dental hygienist, I think she'll like this bill. So, all
right.
All right. Well, good afternoon. Thank you, members of the committee, Vice Chair Kagan, and for the record, I'm Clarence Lamb, Senator in District 12. This bill, SB 306, seeks to build on legislation that the Senate passed unanimously back in 2019, which allowed dental hygienists to provide services in nursing homes, assisted living programs, group homes, adult daycares, as well as physician offices. In addition to these locations, this bill also adds offices of nurse practitioners, certified nurse midwives, and licensed certified midwives. Although there are a variety of ways that this bill could help improve dental care, we believe that it will be particularly impactful during pregnancy. So, for example, a nurse midwife running a birthing center could bring in a hygienist to provide their patients with preventive dental services. Due to the physiological changes that occur during pregnancy, pregnant women are at increased risk of a variety of dental issues, probably no surprise. The American College of Obstetrics and Gynecologists estimates that 40% of women experience some form of periodontal disease during their pregnancy. The risk of pregnancy-related dental issues is also higher for patients who are members of marginalized or otherwise underserved communities. In addition to the physiological causes of pregnancy-related dental issues, many patients have difficulty accessing a dental provider while pregnant, which further increases their risk of dental issues. The American College of Obstetrics and Gynecology found that 56% of women do not see a dentist while pregnant, and thus it's becoming increasingly recommended that providers during pregnancy care offer and help coordinate dental care for their patients. If passed, this bill would help bridge that gap between pregnancy care and dental care. In addition to maternal dental health, prenatal and postpartum dental care has significant impacts on children's dental health. There's a wide body of research that shows that having a parent engaged with routine dental care increases the likelihood that a child receives routine dental care. By lowering the barriers of initiating dental care, this bill would help facilitate a permanent relationship between a pregnant patient and their community dentist, which would have, we hope, lifelong positive impacts on the patient's health and the health of their child. I believe that this bill is an important addition to the state's 2020 decision a few years ago to expand Medicaid to include postpartum dental care, and the discussion this year to add dental adult coverage to Medicaid. Lastly, this bill maintains all the provisions that dentists agreed to back in 2019. Hygienists will be required to be supervised still by a dentist. Services provided would be limited to basic preventive care, such as dental hygiene instruction and the application of fluoride, unless other services are ordered specifically by a dentist, in which case the supervising dentist would also be required to examine the patient following an initial appointment, as well as at least once every year thereafter. I have reviewed the testimony from the Dental Association and the Dental Board. I think their concerns are a little bit of a misunderstanding of the role of certified nurse midwives and certified midwives themselves. I know that definition for certified nurse midwives and certified midwives can be a little confusing, but these providers are licensed in Maryland as independent providers already, and they provide a comprehensive array of services to their patients, including primary care. We do trust these highly qualified individuals to provide prenatal, postpartum, and delivery services, and as a result, I don't believe that there's any reason that they can't provide the consultations also called for under this bill. And additionally, cutting them out of the consultation process may reduce the quality of care because of a hygienist. If a hygienist would be limited in their ability to get information from the patient's provider, particularly if that provider happened to be a midwife. So I appreciate the consideration of this bill and would hope that the committee review this with a favorable report. Happy to turn it back to the panel.
Thank you very much, Senator Lamb. The lead witness is going to be Jan Krebs from the American College of Nurse Midwives. I see you here. Welcome, Ms. Krebs.
Thank you so much, Senator Kagan and committee members. And I will be brief, and then we'll see how far we get with questions. I am a certified nurse midwife. I practiced in Maryland for more than 30 years, and I represent the American College of Nurse Midwives Maryland affiliate. As Senator Lamb said, most people associate midwives with pregnancy and birth, and that is the core of our practice. We've known for a long time that obstetric and dental providers need to work together during pregnancy and postpartum. Further, the risks of dental illness and lack of access to dental care are both higher in underrepresented communities, such as those receiving Medicaid. And Maryland Medicaid does cover dental care in pregnancy and postpartum, but Medicaid coverage only works if we can connect patients to that dental provider. Additionally, we know that many women rely on their women's health provider to manage their health needs. And midwives also provide access to healthcare from adolescents through maturity, not just for family planning, but for health maintenance. Our education in pathophysiology and pharmacology is analogous to that received by nurse practitioners. Actually, in many programs, it's the same class, particularly in areas where fewer resources are available. Being able to offer co-located women's health and dental hygiene and an assessment for referral will contribute to better outcomes. So we urge passage of Senate Bill 306 to support innovative partnerships. And that actually includes the birthing centers, which, yes, are primarily birth, but often offer programs beyond the pregnancy cycle that can support good health across time. So we do ask for a favorable report on this bill and the inclusion of midwives as consultants. Thank you.
Thank you so much. The next witness, George Axe, Maryland Dental Action Coalition. Mr. Axe?
Yeah, thank you, Madam Vice Chair and members of the committee. My name is George Axe, and I'm a retired board-certified pediatric dentist, and I appear to voice strong support for Senate Bill 306, expanding the practice scope of dental hygienists to authorize working under general supervision in offices of nurse practitioners, nurse midwives, and birthing centers. Having spent 25 years in teaching hospitals, including as chairman of the Department of Dentistry at Children's National Medical Center, I left retirement from Maryland's Eastern Shore to become director of Chesapeake Healthcare's Department of Dentistry. While there, the department grew from 29 staff to 70, including a 250% increase in dental hygienists, and we greatly expanded their role as public health leaders. This afternoon, I'd like to speak about the alliance between nurse midwives and dental hygienists, perhaps healthcare's two most patient-focused specialties. Dental hygienists, like midwives, are incredibly fastidious. They're cautious, quality-oriented, and mindful of a patient's entirety, especially their medical history. This may be inflammatory, and luckily nothing can be thrown at me through my webcam, but I believe dental hygienists are often far more attentive and responsive to their patients' needs than our dentists. While at Chesapeake, we initiated an innovative program implanting hygienists in obstetrician offices where they worked very closely with nurse midwives. The result was improved ability to screen, identify, educate, refer, and treat expectant mothers often in great need of dental care. These parents-to-be were motivated by our nurse midwives and hygienists to obtain care and were among the most motivated, reliable, and thankful patients you could ever imagine. The phrase win-win is overused, but this was a win-win program that allowed consumers and professionals to both come out on top. This proposed legislation will only help solidify Maryland's role as a leader in the nation's oral health care for children, adults, and expectant mothers. Thank you, Madam Chair.
Thank you very much, Mr. Axe. Scott Tiffin, I see you are here from the Maryland Nurses Association, Maryland Dental Access Coalition, Maryland affiliate of American College of Nurse Midwives. Welcome back, Mr. Tiffin.
Thank you, Madam Chair and members of the committee. Again, my name is Scott Tiffin. I'm here on behalf of the Maryland Dental Action Coalition, the Maryland Nursing Association, and also the American College of Midwives. I mostly just wanted to be here to help answer any questions in case anyone had any, but also wanted to echo Senator Lamb's point about we were reviewing the dentist's testimony. We do think they have a misunderstanding of the role of midwives and certified midwives. And we are working to set up a meeting with the dental board to kind of chat with them about it. And we definitely extend the same invite to the association as well. So we just hope you guys will give a favorable report to this important bill, and happy to answer any questions.
Thank you very much, Mr. Tiffin, for your brevity. Katie Batani, who is a dental hygienist. Ms. Batani, you are next.
Thank you to the chair, vice chair, and committee members, and Senator Lamb. My name is Kate Batani, and I've been a dental hygienist for 20 years in Maryland and have worked in various public health roles over the past 10 years, including a former position at the Maryland Department of Health in the Office of Oral Health, leading a multi-year federally funded project to improve the oral health of pregnant people in our state. I'm here to enthusiastically support Senate Bill 306. I've seen the impact on pregnant people who suffer from oral diseases and pain in their mouths and who face challenges accessing the dental healthcare system. I'm also aware of prenatal providers, including nurse midwives, who have worked closely with dental hygienists in Maryland to effectively integrate oral health into prenatal visits, including referrals to a dentist and follow-up on those referrals. Only about 1 in 4 pregnant people enrolled in Maryland Medicaid sees a dentist during pregnancy. And this is for a variety of reasons, including being unaware that they're eligible for dental coverage during pregnancy, having difficulty finding a dentist that accepts Medicaid and who will provide dental care throughout the entire prenatal period, experiencing struggles with transportation, having safety concerns about getting dental care during pregnancy, and this is just to name a few. SB 306 addresses these issues by expanding the settings where a dental hygienist can practice and the types of healthcare practitioners with whom they can consult before providing dental care to pregnant and postpartum people. This bill will improve access to care for these patients by breaking down barriers that get in the way of individuals receiving the care that they so desperately need. As licensed healthcare professionals who are education and prevention focused, dental hygienists working in partnership with their dental and medical colleagues can play a vital role in bringing oral health care to where people are, helping to eliminate oral health disparities and improve health equity in Maryland. I believe strongly that dental hygienists should not only be present in dental offices, rather they should be integrated into the broader healthcare delivery system, working with primary care providers, social service professionals, and others to improve the public's oral and overall health. And with that, I strongly urge you to support Senate Bill 306. Thank you.
Thank you very much, Ms. Batani. Anna Rodney, Mom Cares. Ms. Rodney, you are up next.
Greetings to the co-chair, the chair, and the committee. I'm here. My name is Anna Rodney. I'm representing myself as a doula. I do also serve as the executive director of Mom Cares here in Baltimore City, but I am representing myself as a doula here in support for the Senate Bill 306. Since the beginning of the pandemic, birthing individuals have been looking to actively seek more diverse options for medical care for their reproductive health. Midwives represent that to many, in that midwives serve an important purpose within the reproductive health timeline. Midwives are not only employed to assist in the birthing event, they also have the ability to support throughout the spectrum of conception and reproduction, as we've already talked here today about, including routine checks, screenings, and just general health practices for those who are interested in accessing that care. In general, having access to dental care within the doctor's office is important to ensure those who need the care get it, and to exclude midwives from this bill would effectively shut out a portion of the population that is actively seeking other health options that serve them the best. As we've already mentioned here, I will keep it brief. We know that during pregnancy, because of hormones and different changes in the body, a woman's dental health is affected. And while speaking as a doula who supports families, making a number of different appointments is just not always feasible, especially when you are facing barriers as far as transportation and income. And so having a dental hygienist in the room with the midwives would be definitely helpful and supportive to making sure that those who are interested in the service have access to it and aren't expected to pick up more of a load when they're already carrying a significant load in pregnancy. I ask for a favorable report on this bill. Thank you.
Thank you very much, Ms. Rodney. We appreciate what you do as a doula and providing that service.
Thank you.
Three witnesses that are favorable with amendments. So let's kick off with Dan Doherty again, Maryland State Dental Association.
Trying to get unmuted, Madam Vice Chair. Excuse me. I'm Dan Doherty here on behalf of the Maryland State Dental Association supporting Senate Bill 306 with amendments. And I've laid out a lot in my testimony. The amendments look long, but they are not that complex. They're long because of the way the original bill was structured. And I'm going to go right to what those amendments do and what they don't do. The bill separates offices into physician, nurse practitioners, and nurse midwives. Does not treat them all as the same as a clinical office. The dental hygienist and the dentist and the provider in all three scenarios consult in the treatment of the patient. Where there is a difference between nurse midwives and nurse practitioners and physicians is if there is a change in the patient's physical history, medical history. The nurse, the dental hygienist must consult with the dentist. In the other two scenarios, it's an either or, consult with the dentist or consult with the physician. But because of the type of things that patients, dental patients can suffer from pre-medication and a number of other things, which we feel really require the dentist to be involved or a physician, we have eliminated that the hygienist in the change of medical history can consult only with the nurse midwife. In all other aspects, the three providers consult about that patient. The other amendment is a technical one from the previous bill or the current law. And that current law says that before the initial treatment, if the patient's medical history changes, then there must be consultation. Well, that should be before any treatment. So we feel with those amendments, although they're rather lengthy, it's rather simple, we can support the bill. We think it is a good venue or a good entree for an individual to get a dental home, and we support that concept. So we would urge you favorably to consider our amendments and give the bill a favorable report.
Thank you, Mr. Doherty. I didn't realize you guys couldn't see the clock, but we can. So Dr. Doring, nice to see you again. Welcome back to EHE, Maryland State Dental Association.
Yes, hi, thank you, Madam Vice Chair and members of the committee. My name is Charles Doring. I'm a general dentist in Rockville, Maryland. I am also on the medical staff of several nursing facilities in Montgomery County, and I also provide home care visits for those patients that are homebound. So I do advocate providing dental care for patients in non-traditional dental settings. And we look forward to working with dental hygienists and our medical colleagues to do this, but we want to do it in a safe way. I want to mention I'm also a Medicaid provider through the Maryland Healthy Smiles, and I'm also on the Maryland Oral Health Care Task Force. So we've discussed a lot of issues such as this. As Mr. Doherty stated, there are conditions that change with the patient, medical conditions that can affect dental care and vice versa. So we just want to make sure that this is done with proper consultation with the whole team together to provide the best care for our patients. So I ask that the MSDA is willing to work with the sponsor and other parties to work out language that provides safety. So I ask for a favorable report with amendments. Thank you.
Thank you, Dr. Doring. Make sure you're taking good care of my Rockville constituents there. Stephen Dorgan is going to wrap us up with the Maryland State Dental Association.
Thank you, Madam Vice Chair. My name is Dr. Stephen Dorgan. I'm a practicing dentist in Prince Frederick, and I am the current president of the Maryland State Dental Association. Maryland State Dental Association recognizes that this is an opportunity for patients who otherwise do not have a dental home to find one, and we're in full support of hygienists being able to provide care in this in the prenatal and postnatal care. For the same reasons that Mr. Doherty and Dr. Doring have voiced, we do ask for favorable reception of Senate Bill 306, but with the amendments, and again, in regard for the safeguard of patients. Thank you.
Thank you very much, Dr. Dargan. So colleagues, also just written MACHC and MDHA and Maryland Academy of Advanced Practice Physicians and the Public Justice Center, written in opposition is the Maryland, the Board of Dental Examiners from the Department of Health. So that is what you can find online or in your packets. And we do have questions. Start with Senator Lamb, sponsor of the bill.
All right, great, thank you. So I guess I know from that list that the Physicians MedChi is not opposed, but I guess maybe this is a question for Dr. Doherty. And I guess is it from your testimony the sense that nurse midwives or certified nurse midwives can't provide an update on patient history? Is there some concern with that? Then I have a second follow-up question. Go ahead.
There is concern that for certain types of changes in medical history or medical condition, that the dentist is more appropriate in discussing how to approach that with the hygienist. One of the things that could be involved is a patient who's been pre-medicated or received penicillin or amoxicillin has developed C. diff, or is at risk for C. diff. Well, I don't think the nurse midwife is the most appropriate person.
Dan,
I think the dentist is.
Dan, what's C. diff, please?
Pardon?
What is C. diff, please? Could you please translate?
C. diff is an infection, and that's what it is. C-diff. It is an infection that's caused by the good flora being basically minimized or wiped out by antibiotics, and C. diff takes over. And I know a good bit about it because 8 years ago, my wife almost died because of it. So
I appreciate that. C. diff is actually short for Clostridium difficile. So if someone's looking it up, you'll find that if you Google that. I guess just trying to figure out the best way to address this. I think there was, an extension from the Nurses Association
to meet with all of you. Have you taken them up on that offer to do so?
I
Are you
have.
willing to meet with the nurses in the Nurse Association?
I submitted the amendments to Ms. Elliott. The last I heard from her, they were looking at them and were to circle back to me, and they have not gotten back to me as of now.
Hey, Senator Ellis, you have a question.
Yeah, thank you, Madam Vice Chair, Senator Lamb. Bill, discussion. I think a lot of people think of a nurse practitioner. I'm not as a dental hygienist, as basically they do cleaning and that's it. Very important role, and several of the doctors, dentists have been alluding to this. There are conditions in patients that could be impacted by that particular cleaning. I think Dr. Daugherty mentioned folks who have to get pre-medicated with prophylactically antibiotics and stuff like that. So the question is, are nurse practitioners, certified midwives trained in all these particular negative outcomes that can affect patients who are going through, seems like a simple cleaning, to make sure they are protected going through the process? That's it.
Okay, who can answer that?
I think Jan Krebs could definitely be the respondent to that.
Krebs?
Thank you. Yes, we are educated about the risks of procedures. I will stipulate that in the case of a dental procedure, if someone was if the hygienist was asking me about pre-medication, I probably would use the ADA document that's on their website, not behind a paywall, which points out how few patients today would require pre-medication. Certainly, anybody about whom I was not certain about my personal knowledge, I would consult either with a physician consultant, or I would recommend that the dental hygienist call the dentist. But to eliminate our ability to make decisions, not just in big issues, and yes, sir, I agree that pre-medication can lead to C. diff, and C. diff is a terrible disease. But that part of our education is to know when to ask for help. And so if there's a condition where I or any midwife didn't know what the right answer was, I hope that we would have the good sense to do what any nurse practitioner or any general physician should do if they don't know the right answer, which is consult with a colleague with greater knowledge.
Yeah, so you're saying from the spectrum of nurse practitioner all the way through to certified midwife, the knowledge is there about these dental procedures and the possible effect on patients' heart and during simple, say, dental hygienist treatment like cleaning.
What I am saying is that if I am asked and I'm not sure, I would, number one, look up the answer. And if I wasn't certain about that, I would consult, because that's what we do. Okay. And in this case, the consult might be to the dentist. Interestingly, sir, we also, during pregnancy, find that fairly often I'm going to pick a non-dental example. This is more common in my practice. We'll say to someone, for example, I'm concerned, I think you need to be with a therapist. I'd like you to see a psychiatrist and get started on an appropriate med, at which point the psychiatrist will call us back and say, well, which meds do you suggest during pregnancy? So do I know everything? No, sir, I don't. But I do know enough to try to look it up or ask for help.
Right. Okay, well, thank you for that. I just wanted the answer. You have the answers and I don't. So thank you for sharing with me. I really appreciate your candor. Thank you, ma'am.
Senator Ellis, and we're going to wrap up with Senator Croza.
Thank you, Madam Vice Chair. I am not a medical person, so when I ask my questions, I'm literally trying to learn about process. And maybe Senator Lamb, I'll direct this to you, but if you want one of your witnesses to answer, that's fine. I first of all, trying to make sure that this authorization given to the dental hygienist wouldn't result in any delays in treatment. So I wanted to understand that. And then can you walk me through an example, because I'm still trying to figure out what problem we're trying to resolve with the legislation. So, and again, I'm not a medical person, so if you can walk me through it, that would be great.
Sure, so happy to do that. Can you hear me? Yeah. So I think the problem it's trying to resolve is that we have a lot of individuals throughout the state that through their prenatal care that they access, that they may be getting their primary care from nurse midwives or certified nurse midwives, that they may not be going into a physician's office, for example. And as a result, these folks oftentimes have more limited access to care, and they may not be going to their dentist either. And so this would allow these practices that have certified nurse midwives for the certified nurse midwives to serve as a supervising provider for these dental hygienists, just like a dentist would serve as a supervising provider for them as well. And I think based on existing statute, physicians can as well. So this basically just, I think, extends that ability to certified nurse midwives who already under current statute have the ability to kind of practice semi-independently, just like a nurse practitioner would and a physician's assistant would.
So is it the nurse midwives and the patients that are seeking this authorization?
Can I just add one possible clarification that might help? So this is to help connect the patient back to a dentist. That's really the primary goal. And so these folks who are getting their care from midwives or nurse practitioners could bring these hygienists into their office to provide some of the introductory care, like the basic teeth cleaning, the oral exam, and those types of things, with the goal of permanently connecting them back to a dentist and an actual community dentist to provide ongoing care for them and for their child in the future.
Really to address an access issue. So it gives them another point of accessing this type of dental care.
And that would be coming then from the midwives who see that as a benefit?
Yeah, the midwives would have to bring the hygienists into their office.
Okay. Thank you. Thanks for your patience.
Thank you, Senator Carrozza. Thank you, witnesses. Thank you, Senator Lamb. That completes the hearing on Senate Bill 306. And that completes our hearings for the day. Tossing it to the chairman for any announcements.
First of all, thank you, Vice Chair, for chairing today. We have a lot of bills and some controversial tomorrow, so it may be a longer day. Thank the committee, thank our witnesses for joining us today. We will take all of the testimony under advisement and hopefully move the bills to voting lists in the very near future. Thank you, and we're adjourned.